Okay, so we're going to start the second and last part of this meeting. Please take your seat. What are the objectives of this afternoon? Andiamo avanti? No? Ça marche pas? Voilà. So the first objective is to share experiences among forerunners. There will be, the first session will be 8 brain health services that will present their structure, how they work, what they do in practice. And we hope that this will promote the exchange of ideas, protocols. You know, this is the usual business as usual in science. The second objective is to say, okay, we are developing in Amsterdam, in Stockholm, in Milan, we're developing these new patient journeys, but we're not working in a void. There's other stakeholders which are involved. There's patient advocates. I've just exchanged ideas with Alzheimer's Geneva. There's professional societies, there are nuclear medics, there are neuroradiologists who will be involved, there are laboratory chemistry physicians who will be involved, and others. Pharma, of course, great stakes. Research funders, we have, this morning there was one of the major Swiss funder of Alzheimer's research in Switzerland. They may wish to, we would like to have their support to move our projects forward. And we also would like to have the support of charities, of pressure groups, of the World Dementia Council, of WHO, the European Brain Council. And last but not the least, the objective is to inform healthcare providers. The chief executive officer of a private hospital or a public hospital who should become aware that this is a new opportunity in healthcare. It's a brand new opportunity that they may wish to grasp and launch in their own place, in Rome, in Bordeaux, in Berlin, in wherever you wish. And the outcomes that we expect is that programs, currently active programs, will be strengthened by sharing ideas, which is, again, business as usual. And we hope that everyone else, all participants, will be able to have a grasp of what really means developing a brain health service for the prevention of dementia, beyond the scientific papers, beyond what you heard from the recommendation this morning. What does it mean in practice? If you wanted to do something similar in your place, what do I have to do? What am I supposed to do? There will be the first 8 talks will be, as I said, from pilot experiences, but you will hear 2 different things. I had the opportunity to see the slides in preview, so I know what will come. So I realized that there's basically 2 groups of services and institutions. There's one group where they have research projects on prevention, and there's another one, another group where they have patient journeys. So these 2 categories, research projects on the one hand and patient journeys on the other. This should be kept in mind because what's the difference between a research projects and patient journey? These are research projects. It's the letters of the alphabet, the evidence about what is a risk factor, what is the size of the risk, what's the best way to communicate the risk, what's the best intervention, what's the efficacy of intervention 1, the efficacy of intervention 2. These are research projects. This is the patient journey. This is placing the evidence available into a logical and coherent story that allows a given patient to enter the clinic and move through a number of medical acts, a number of exams that follow an algorithm, a clinical logic. This is a patient journey, and it's not trivial to select the good evidence to concoct a patient journey. Okay, I've talked way too much, and it's my pleasure to ask the first presenter, Federica Ribaldi, to come to the podium. Federica will present what we are developing in Geneva. You have 10 minutes, right? Yeah. You have 10 minutes. Please stay to time because there's 8 presentations overall. So, Federica, please. You need this.
Good afternoon, everyone. Okay. Good afternoon. It's a great pleasure to be here presenting our brain health services here in Geneva, and it's an honor to start this session about the pilot experiences. So I'm excited to share with you our journey, let's say, to get to the clinical deployment of brain health services here in Geneva. So we started from the Geneva Memory Clinic workup, which was a standard memory clinic workup for people with cognitive impairment, but to, let's say, address the needs of the increasing population without cognitive impairment, we had to adapt it, of course. Then we started a series of research projects dedicated to the 4 pillars that we heard this morning. And then we started the setup of the clinical protocols and of the material tool, digital tool, to really put it in place. And we are now ready for the clinical deployment, or we hope so at least. So what's the environment? So the environment is the Geneva Memory Center, in which we have a waiting room, a room for lumbar puncture, for the infusion, for the medication, a biological lab, and of course, research offices, a room for neuropsychological evaluation. The patients arrive to the memory center through their general practitioner, or they can come on, spontaneously or through research projects. Our hospital is equipped with a 3 Tesla MRI scan, a PET scanner, and machines for biomarkers extraction, fluid, both plasma or CSF. Our personnel consists in physicians, meaning neurologists, geriatrician, and psychiatrists, but also neuropsychologists, psychotherapists, researchers with different backgrounds, and great administrative staff. Our population consists of 4,500 patients, 22% are SCD, and in the last year we had 1,050 new patients. And this is just to show you the increasing number of SCD across the years. Our clinical workup consists of a first visit in which the medical history is collected with the neurological exam, cognitive screening, I mean, a very standard first visit in a memory clinic. Then we have an in-depth cognitive assessment, markers collection, MRI, and for some of the patients also CSF and blood. And what we have added in the memory clinic workup is a visit for deeply phenotyped people with no cognitive impairment, in which we collect the lifestyle risk factor, physical risk factor, and psychological risk factor, personality traits, and so on. After that, we propose to them to participate to our research program, in which we collect other biomarkers and cognitive and metacognitive features, and we follow them up to 8 years now, every 2 years. So moving to the research project, what we have done is to run a series of research projects to identify the SCD at higher risk, either through imaging or plasma biomarkers or clinical features. And also regarding risk communication, we have a joint project with the Cologne and Bonn team to develop a framework for cognitive risk communication. And also within the AMIPAD study, we worked on the disclosure of amyloid PET. Moving to the other two pillars, so risk reduction and cognitive enhancement, we ran projects on multi-domain intervention like finger-like or multisensory stimulation or non-invasive brain stimulation, cognitive enhancement, and so on. And we gather some evidence on this. Moving forward, what we've done and where we are for the brain health services setup. So as you all know, after this morning talks, we, in the special issue we've done a few years ago, we gathered the clinical evidence and we provided clinical guidelines for all the four pillars, so risk assessment, communication, risk reduction, and cognitive enhancements. What we have done in the last year is to prepare the material to be ready for the clinical deployment, meaning prepare the paper and pencil case report form, make the calculation for the risk assessment, but also preparing digital tools to facilitate let's say, delivery of these tasks. Moving to risk reduction and cognitive enhancement, of course, as you have seen in my previous slide, we didn't have personnel for this kind of activities. So what we have done is to set up collaborations with the nutritionists, expert in non-invasive brain stimulation, to set up the protocols for these activities. And then we finally arrived to the patient journey. So before going into the details of it, I'll just make some assumptions. As we heard this morning, we have different risk factors to be assessed. And of course, I mean, there's nothing in literature so far that is assessing all of them with the same period, let's say, of assessing risk factors. So we don't have relative risk in one single study. So of course we had to adapt to it. For example, Livingstone, the 12 risk factor, do have a different period of observation than Brookmeyer and Abdallah, that is giving us a risk that provided with us the relative risk for amyloid and tau, which is a 10 years relative risk. Another assumption we made is that vascular and neurodegenerative pathway are orthogonal. This has been proven in the literature for years, and also in a recent paper published in JAMA Neurology recently. So vascular risk factors and degenerative risk factors are independent predictors of cognitive decline. That's our assumption. And of course, there are other assumptions we had to make. I won't go through all of them for interest of time. Okay, so that's the patient journey. That's a very dense slide. So I will show you later each of the steps, so do not worry. So that's just to give you an overview of the overall process. There's a first visit, which is very similar to the visit we currently do in memory clinics, in which we collect medical history, cognitive screening, but we just added the lifestyle risk factors. And then there will be a cognitive battery, MRI, and blood collection. People that will result mild cognitive impairment or functional cognitive disorder will be directed either to the standard memory clinic workup or through other departments. And then the others will have a second level screening with PET or CSF and will be categorized based on their cardiovascular or degenerative risk. They will all have risk communication, and we'll see later how. And then we'll propose them depending on their their risk, a non-pharmacological multi-domain intervention if they are at high cardiovascular risk, which would be finger-like, and if they are at high degenerative risk, will propose a biological multi-domain intervention, or the combination of both in case of high cardiovascular, high degenerative risk. Of course, we'll propose to all of them non-invasive brain stimulation and cognitive training as cognitive enhancement activities, and then we'll follow them up every year. So what we have developed are tools for risk assessment and risk communication. Let's start with the risk assessment. I don't know if the video works. No, spoiler. So can we make it? Okay, thank you. So this is how we'll collect the 12 risk factors plus, all the risk factors that are shown here. So this is just an example of a person, 70 years old, female, with low education, not traumatic brain injury, high blood pressure, high alcohol consumption, and like no normal BMI, currently not smoking, and then we'll have no depression, as well as no social isolation, but definitely physically inactive. He lived in Geneva, so no air pollution, and diabetes, yes, amyloid positive, neurodegenerative positive. That's, it's just an example to show you how our tool works, and then we'll go. The same data are entered in this risk communication tool we developed thanks to Augusto, which is working with us at the Memory Center. So on the left, we just entered the same data that have been taken during the risk assessment, and here the infographics shows the baseline risk and that is based on age and sex, and his risk based on the actual risk factor he has. And then this pie chart shows the contribution of vascular and degenerative risk. So moving to the risk reduction, we will propose to people with high cardiovascular risk vascular intervention, let's say, which is a multi-domain finger-like intervention, as I said before. And then for people that will have a high degenerative risk, will propose a multi-supplement intervention, which consists of a multi-strain probiotic slab 51 that demonstrate to have an anti-inflammatory and neuroprotective effect. Suvenade, I guess you all know, anyway, showed a reduction in atrophy and let's say maintaining the functional and cognitive performances. A multi-mineral supplement which is composed by cocoa extract and multivitamin mineral, which showed a positive effect very recently on global cognition and episodic memory. And then melatonin, I got several assists this morning with the discussion about sleep, and of course, we all know the neuroprotective effect of melatonin, which we know that melatonin decreases across the disease stages in Alzheimer's disease. And I guess I'm late. So this is just to show you the cognitive enhancement activities. We propose this protocol, which are the one validated, the one, let's say, that showed positive effect in subjective cognitive decline. Actually, there is something I have to say on this slide still. So the degenerative intervention, so each of these supplements showed at least one signal of efficacy, but they've never been tested together. So that's an important point. So, okay, so let's go ahead. So what's our plan? So we are now beginning 2024. We are ready to identify the population, so the subjective cognitive decline at risk. We know how to do risk assessment. We have our tool. We kind of know how to communicate the risk, and we also have our let's say, a plan for interventions, but of course, these tools have never been, these interventions have never been tested before. And we also know what kind of cognitive enhancement protocol to use, but we don't have at the moment the equipment at the memory center. So we'll plan to start in 2025. And our first patient with the whole patient journey will start in June this year. And then, I mean, on the right, you have the whole plan that will be explained later on. Of course, there are many hurdles and funding and problems, let's say, issues with fundings. We'll discuss possibly later during the discussion. I'd like to thank all the, of course, participants within the task force, all of you for your attention, and in particular, people from the Memory Center, Augusto, Christian, Olivia, and Matilde, of course, because without them, it couldn't be possible, and Daniela Tomade, which started with us this initiative years ago. Thank you all for your attention.
Thank you. Time for discussion. Let me just change hat for a second. I take off my moderator hat. I put on the head of the head of the memory clinic. What you have heard, we know that there's plenty of gaps of evidence, but the idea is to build the infrastructure, the scaffolding of something that will be nourished, that will be fed with evidence as it will come along in the future, in the next few years. So it's a pilot study, you know. It's not supposed to be to give all the answers. There's some assumptions that we know they can be criticized, but still we have to start. Someone said this morning. We have to start somewhere. This is where we decide to start. But we will have more the opportunity to have a general discussion, and you will hear the business case in between in the intermediate section of today. There will be people from Deloitte who will present the business model, the business model for this for our brain health clinic, and before that, the business case for dementia prevention in Europe. That will give a set the stage. Thank you, Federica, and it's my pleasure to ask Craig, my friend Craig Ritchie, to with whom with whom we started this together with Bruno and Craig. We started all this journey in a taxi a few years ago.
Yeah, I've only got 10 minutes, so we'll leave the taxi aside for the moment. But first of all, thanks so much, Giovanni, for your leadership with so many others in this field and for pulling this together and inviting me to present what we've been doing in Scotland for the last few years. That image, by the way, up there, your brain is amazing, let's keep it that way. That's the strap line for Brain Health Scotland, and that's the kind of imagery that we have in all our public-facing documents. So you can see already from that we're talking to a different community of people about brain health, and it would be traditionally the case that older people closer to a dementia syndrome. Yeah, I thought I'd better throw up some disclosures because in the last 18 months, I've pivoted from being a full-time clinical academic to running my own company called Scottish Brain Sciences. And I'm the CEO, founder, and majority shareholder of that company, and I do consultancy work for these various companies as well. So this is actually a slide from 2020, which showed the initial starting place for this journey actually was with Anna Borthwick, Henry Simmons from Alzheimer's Scotland, in a meeting that we'd had the previous year with the First Minister of Scotland. Now, I was really fortunate enough over the years to lead the project called EPAD, and EPAD brought many things with it, but probably the most important thing it brought, the two most important things it brought were Number one, conversations with the participants who are asking those questions, what's wrong with me and what can I do about it? And for those who don't know EPAD that well, these were people who did not have dementia, but were high risk of developing dementia. So we were listening to that narrative consistently from our research centers and from the patient engagement we had as part of the project. The second important part were the discussions in taxis. There's a community of investigators, many of whom are still here today, who are having these conversations about whether or not the current services we had were fit for purpose for where we thought we should be operating in 10, 15, 20 years' time. And that's why I think in some ways, certainly in Europe, the Brain Health Initiative had at least a major stimulus, if not its own foundation. And to pick up on Giovanni's point, when we spoke to the First Minister in 2019, we weren't presenting a full data set of conclusions on this, that, or the other. We were almost saying to her, look, we think the evidence base is mature enough, the need is great enough, that we should actually fly this plane as we're building it. And the scaffold, as you put it, was really important to put in place before we nailed absolutely every risk prediction algorithm, before we actually did all the RCTs of whether or not this worked or that didn't work. So we felt we really needed to get going with developing brain health services. So this is the environment. It's worth about 3 slides in the environment. And by the way, there's not a huge amount of detail in these slides. That's who I am. I like being up there somewhere. What we decided was that we weren't going to just set up a brain health clinic in isolation of a brain health approach for the whole country. I should remind people, of course, that Scotland is fully devolved in terms of healthcare and social care from the rest of the UK. So all the decisions are made at a national level within Scotland. Starting at the bottom of what we call the brain health pyramid, which is these public health approaches and interventions like the poster you saw at the beginning of the talk. I won't go into all the details of all the other things we've done, but we've also got a schools program, for instance, an 11-year-old school children. It's on the national curriculum in Scotland to run a course about brain health in schools. And that's something we're very proud of. 20,000 children in Scotland have taken that course. You then work up the pyramid to the high-risk populations, those maybe with a family history or a history of head injury, and I'll come back to that in a second about people with head injury. Then we have and I'll show you this in more detail next slide, we have what we call brain health hubs. These are community-based centers where people can walk into. This is part of our patient pathway, or person pathway, I should say, where people don't necessarily need a GP referral. They don't have to go to somebody else to be referred into the service. They can walk in off the street. And all the awareness raising that we're doing around these targeted populations, public health, is driving people to have interests and concerns or kind of a willingness to know more about their brain health and what they can do about it. And at the top of the pyramid is a more traditional clinical service. So this is the kind of the pathway for the clinical service. So as I've mentioned earlier, the starting point on the left is either, yes, we do accept GP referrals, or, and I think the majority of people are actually coming in off the street, if you like, a walk-in service, which is obviously accessible to the community. Those colors of the red, amber, and green are, of course, kind of a high-level attempt to define a high-risk, medium-risk, and low-risk population for future Alzheimer's dementia or progressive Alzheimer's disease. And what that then shows you then is these triage points where people will come to various stages of their assessment. The front end, it might just be they want some information, they want some health literacy to be improved, they maybe want their risk factors to be looked at, and they might leave at that stage. Or there might be a concern to the nurse, the brain health guide at the front end says, actually, we think you should come speak to the nurse. The nurse will then take them into their office and they'll do the blood pressure, they'll do a more detailed assessment. And on the basis of that, they may well see the consultant. Now, this clinic is, I'm glad to say, is now fully operational in Aberdeen. It started in December last year. Hugh Masters, who's joining the call later, is very much in charge of running that service at a Brain Health Scotland level. Scores of people have been through this. I haven't got data to say how successful it's been in terms of patients, how they react to it, and what sort of people are coming through. But watch this space; that will come in due course. For those who can see, I know it's a sort of small slide, but the stage 2 within the NHS hasn't really evolved as we'd expected it to. So the more detailed assessment of CSF and neuroimaging is to be delivered, if you like. What I'm expecting is that my company, Scottish Brain Sciences, because we have the capacity for these things in the company, I'll come back to this later, will provide that service to be a handoff between the NHS and the company to be able to provide that. So the third thing about the environment is, and I challenge anybody in this room to have a better view from their clinic than I do on a Wednesday afternoon, because that's my clinic at Murrayfield Stadium. So I actually have a box, a director's box, to do the brain health clinic for ex-professional rugby players, both men and women. And I've been running that clinic since May 22, and I've seen 30 people. And I can actually say the majority are actually women. There's much more engagement from the ex-professional women in that service. It follows exactly the same model as a brain health clinic, but it's a single person clinic. I'm doing it all on my own. I do the history taking, I do the risk factor analysis, I do the physical examination. We take bloods for storage for hopefully A-beta and tau in the future and NFL, etc. But just for sort of standard biochemistry and hematology at the moment, and they all get an MRI scan. The one thing that's really important about that service has been the 30 conversations I've had with the people in it, because what they've all said is, this makes sense. This has been valuable. This has been helpful. These are people who've all had traumatic brain injury through playing rugby at a very high level. Quite a sobering statistic from that clinic is that half of the women who've been in that clinic have also had head injuries through intimate partner violence. And the more significant head injuries have been through IPV in their career playing rugby. So one of the other things we do in Brain Health Scotland is some outreach activity to work with charities and groups who work with people, women with intimate partner violence. So I've only got a couple of slides to go. Plans for the future. Number one, the pilot service is being run in Aberdeen by an NHS Grampian. We'll have to look at that data, that information, those experiences, packet it up, and then see what other NHS boards in Scotland will want to adopt that model. This is new funding, by the way, from Scottish Government, which helped to develop this pilot project. I've mentioned already the fact that there might be a handoff in some of the services that are run within the clinic with my new company, Scottish Brain Sciences. We're working very closely together with universities and the NHS in that regard. And that brings in a sort of a research element to it as well. And the third thing is looking at Scottish Rugby, who've actually funded the clinic at Murrayfield. Is there other opportunities for corporations or companies to provide a brain health service as part of like a well-being or a welfare commitment to their employees or former employees? So we're looking at these kind of three ways of getting brain health services out there. It is actually within the Scottish Government's what's called Programme for Government that every person in Scotland will have access to a brain health clinic by 2025. And I think we're the only country in the world where there's a government commitment to everybody having access to a brain health service by next year, which brings me to the last point about the hurdles. So fantastic that from 2019, there's a slight sort of hiatus for a couple of years because of a pandemic. But from 2019, there was a government commitment to support the work of Alzheimer's Scotland, Brain Health Scotland, to put these clinics in place, the National Health Service. But governments are great to stimulate, but they're not very quick to oversee and run and manage. Hence, we've pivoted, if you like, to this triple helix approach where you bring the life sciences sector, the academic community, and the healthcare system together to bring each of their strengths into this sort of partnership against the single objective. And I flicked over it quite quickly, but there's obviously the Scottish model paper, which was published, I think, 2 or 3 years ago. And that's our rule book. And it obviously dovetails very closely with the European initiative. And as long as we stay faithful to that, and we don't go off and develop, multiple different instances of different varieties of a brain health clinic, all will be well. So I will stop there. Thank you.
Thank you, Craig. I believe we have time for at least one question. Maybe the question would be, how did you persuade the government?
Because I'm very charming. No, I think no, well, I am, but no, the reality is, and Scotland's a very small country, so access to high-level politicians is a lot easier than it would be in a larger country. So I think it's dare I say, a big fish in a smaller pond does actually help in terms of having access to that. Had we been able to do this in England or France, Germany, I don't know. I mean, I think getting access, literally sending a letter and asking, she obviously knew us before and what have you, but I think it was that level of access because we're a smaller country.
Makes a lot of sense. Thanks, Craig. We can move on to the next presentation. Mia Kivipelto, you've already heard Mia, who will now tell us about what she has built in Stockholm.
Thanks. Thank you. Thank you so much. I'm happy to continue to give some examples from the brain health services in Stockholm, Karolinska University Hospital. It's really exciting to hear the differences and similarities, but I think also reflects the differences in the healthcare system and what there are many different starting points, as we can see. So exciting discussion. So I tried to follow the templates I got from Giovanni. So let's see how it goes. First was the environment. So our starting point is the Karolinska University Hospital. It's a big major hospital, very advanced, now rated as a number 6 globally. So you could think that that's a good place to start. Well, it is in a way, but there are also challenges because when it's a big hospital, it's government-based, it's taxpayer money. So we also need to be quite careful what we are doing, and there are also many restrictions. On the other hand, if we manage to do something, I think that can be a model for the rest of the Sweden, and it can be scaled up. So this brain health services, we launched that to 22, and it's now included as part of the specialized memory clinic routine. So it's already part of the routine. It's not anymore research project. Of course, we have a lot of research as well. Patients who come to us, they need to come by referral from after memory examination. So we have all the data from memory examination. We started with having the patients from our own memory clinic because that was close. Now we have been opening it up that other memory clinics can also send the referrals. Patients at risk are invited, and we have here a risk assessment, quite simple one to start with, but that can be further developed. This is the bigger environment. It's our memory clinic, quite similar what you have here. We have all these examinations, CSF, PET, MRI. So this data is available, including ApoE and as said, CSF markers. Around 800 new patients are coming to us every year. And we have this fast-track memory clinic inspired by Amsterdam model. And that's where we have implemented the brain health services. We have examination time for 5 days. And after that is actually a very good opportunity to both integrate the research and clinic, asking the participants to be part of various projects or refer them to the brain health services. We have also the unit for clinical trials, which is also one way. So many persons want to be part of different kind of trials. And we have, as you saw, both drug trials and then non-pharmacological interventions. And on top of that, Stockholm, we have 11 other memory clinics. They are not university hospitals, a bit smaller ones, but they have had huge interest to start refer patients to us as well. Why this is important, why we really got interested. Of course, we have our research finger and others, but we also got the question from our patients. They want to have something more. And when we checked who are the patients who are coming to us, many of our patients have subjective cognitive impairment, more than 50%, and 20 around MCI and rest have dementia. And quite small part of our patients actually would be eligible for anti-amyloid therapies. That was 7% from all who are coming to us, 13% of those who have MCI, and 17% of those who have dementia. Surprisingly similar numbers are also from other clinics. There was recently a paper from Mayo Clinic, 5 to 8%. So I think this is what we see in many clinics. There are many patients coming to us who have other reasons or other type of pathologies as well. Well, our risk assessment, this is a bit busy slide, but just to show you, we follow the 5 fingers. And this is a very clinical instrument. So it's kind of traffic light. You have all cardiovascular risk factors, blood pressure, obesity, and so on, physical activity, nutrition, cognitive stimulation, social stimulation. And we answer if the risk profile is green, yellow, or red. Inclusion criteria to come to us is SCI or MCI, 1 red or 2 yellow, MMSE over 24, and independent mobility. One challenge is how to assess cognitive stimulation and social stimulation. Here I need to say we are not yet as advanced compared to measuring blood pressure. So this is absolutely an area which we could develop further, developing tools which are not only for research, but also can be used easily in the clinical setting. This is our first pilot that was conducted last year, around 52 patients, mean age 70.6 and mean education 14 years. A bit, quite highly educated, as is normally the case in these studies. And this here you can see also diagnosis. Here actually big part had MCI, around 60%. We have now just started 1 year follow-up, so I do not have yet so much results from there, but experiences have been very good. They are very happy to come to us, and dropout rate, 12 persons did not want to come back, and that was because of the same reasons we normally have. They have been getting worse, or they were happy. They felt we have already enough information. We don't need to have more. So these were the reasons so far. This is a busy slide, and we don't need to go it through in detail, but what we did was a mapping exercise. What is our current memory clinic, and what is the brain health services? What are the differences? And I think this was very good for us to try to understand and further develop these different type of clinics. And I highlight here just a few parts. At our brain health services, we have now nurse and doctor. At the memory clinic, we have a multidisciplinary team. And because we work so closely together, we can, of course, take advice from these teams as well. In the brain health clinic, we have 2 face-to-face visits and 7 digital visits, and that's the counseling for all these different factors. And we give feedback according to finger, and the follow-up time is now for 1 year. Payment model, funding, that is, of course, the big question. And I'm very happy, sorry, now this is in the wrong place. It should be here, the last line. We have managed to get the government funding for this, what we are doing. So this is, we get reimbursement for the visits, what we are having at the brain health clinic. In the same way, we get funding, or we get paid for the memory examinations. And that's why it was careful or important to start with a very defined target population. And that's what we want to do next or this year. We have planned the patient flow, referrals, day 1 with the visit by doctor and nurse, and then many digital visits, as you can see there. The idea is that the first month is more intensive. You go through the different fingers. Not maybe all participants are needing all of those, but there is the opportunity for that. Then there will be the education, the group sessions for 5 fingers, multidisciplinary team, lectures, and the social component that they can come back to us. And after that, some visits, and after 1 year, a physical visit again. So we use a hybrid model, face-to-face, digital, individual, and then these type of group meetings as well. Hurdles, what are there? What are the challenges so far? Well, I think we need still to work with the referral process, thinking the wider Stockholm area. Finding a personnel who have the competence and interest. We are not yet totally sure what categories. Now we have a nurse, but it could be some other, it could be a physiotherapist, a dietitian, or health coach. So I think there are many kind of opportunities. Finding facilities for these gym sessions, for example, being close where the persons are living, and some other type of meeting points like brain cafe, where people can both socialize and stimulate the brain. Finance, of course, now we have this pilot or kind of clinical routine, but if we want to develop it, if we want to expand it, that's always a question. And as I mentioned, cognitive and social activity and how we measure that should be further developed. We should develop more individualized programs and using more e-health solutions. Implementation gap here is one thing what we need to try to bridge. And then the funding, I already mentioned that, but the more sustainability here. And I hope that these projects, which I mentioned, AD Riddle, for example, can help, because that is really real world implementation. So that's one thing. And we also managed to get some funding in Sweden to really implement finger in different settings. And one more trial to show, we have a big EU trial called LETHE, where we are testing different new technology tools, as you can see here. So we take the finger from face-to-face to digital. And you may also see here that we have been taking sleep and relaxation as well. So that's part of the package. If this works, that could be, of course, more feasible way to support the interventions and also how we measure different things. So this is ongoing right now. And this is my final slides. I come back to this figure I showed earlier. Brain health clinics is here, but we need, like you said, Craig, as well, much more as well. We need to involve primary care and the crosstalk between these entities and the wider municipality level to get there. Otherwise, it will not work. So this is just the starting point. We as an expert center can provide the tools, but we need much more. And the interest in Sweden is great. We have started this wider community level. We have now a network called Finger Implementation Network, and we have had many workshops, and there are already 70 municipalities out of 290 who are part of the Finger Network. So I think we can do it, but we need, of course, a bit more resources to be able to scale it up totally. Final thing was the timeline. This was a tricky one, Giovanni. It was not easy to know exactly where we are, but as said, we are already up and running with the clinic, and of course that is to be further developed. We want to develop brain health registry. I know some countries are having that. We don't have it yet. Blood biomarkers, I think, will change and facilitate this. And I'm optimistic that when we get the new drugs, we have the finger as the starting point, and then we can add them to make it even more effective. And that's my final slide, to make the vision even broader, really moving for the multimodal precision prevention and taking into account all these different factors. Brain checks, you could have it throughout the whole life course, and modifying the multi-domain interventions, taking into account the target population you have, and then also the risk profiles. I want to thank all the colleagues and especially the clinical group who I have been listed there, because they have been doing great work to get this idea through. Thank you so much.
Thank you, Mia. We have time for one or two questions. Before giving you the microphone, I want to take advantage of my position to ask you a question, Mia. Most of your patients are MCIs, but in MCIs, we will shortly have drugs if they're amyloid positive. So shouldn't they be included in a traditional memory clinic first?
Yeah, that's a good question. Sorry, I did not say it clearly. These MCI, big part of the MCI patients do not have the traditional Alzheimer amyloid tau. It's actually very small. So those who come to us normally do not have that type of profile. But that's the nice thing when we work together, you can do both. They can get access to the treatments, and always we start treatments and also recommend clinical trials. So it's not that you need to select one of those, but most of these MCIs who came to us do not have the traditional AT profile.
Thank you, Mia. Hans, quick question.
Yeah, I was just wondering.
Quick one, my friend.
Yes,
I know you.
I was just wondering whether you made some special kind of patient selection for entering your service, brain health service, because in Switzerland we made 2 evaluations, and still you have, as a regular basis, more than 50% of patients being demented on first exam, and you have more than 50% with a subjective cognitive decline. How do you explain this?
Yes, it's a good question. We are, as said, in Stockholm, we are the highly specialized clinic, and we have responsibility for all younger persons. So we get sometimes referrals from the other memory clinics as well. So that's why we have much more earlier cases. So that's one reason. And that also shows again that the mixture of the patient mixture, of course, affects how you design your brain health services. We have the other Karolinska Memory Clinic at Huddinge, and they have a bit older population and a bit more MCIs, so it's a bit different memory.
Thank you, Mia.
Thank you.
Thanks a lot. It's time to move on to the next presentation. Aida Rostam, I will never be able to pronounce it. Rostamzadeh, sorry about that. Co-worker of Frank Jessen, Cologne.
So thank you very much for the invitation to this great event. And I'm happy to show you the activities of our Cologne Alzheimer Prevention Center. So the Prevention Center actually was founded in 2018, and it was the idea of Frank Jessen, actually. And it's part of the University Hospital of Cologne. And it's embedded, or it's a complementary institution to the Center for Memory Disorders. Okay, it's a bit too big, but you see here the campus of the University Hospital of Cologne, all these blue squares. And the arrow above shows the Center for Memory Disorders, and the arrow below shows the location of our Alzheimer Prevention Center. So it's within walking distance, but it's completely separated. It does not have the surrounding of a hospital, actually. You see the rooms, the facilities we have. So we have offices, examination rooms. We have got a 30 square meter room where we do group activities like educational courses or cognitive training that we offer for the people. And we do have a laboratory and freezers for processing and storage of biosamples, which is completely separated for everything we have in our memory clinic at the hospital. So the main goals of our center are to conduction of studies, actually, everything around dementia prevention and brain health, and the provision of health services to individuals. So what is really important in that context is the establishment of the Cologne Alzheimer Prevention Registry. This was established in 2016, and it's a registry for healthy people that are interested in dementia prevention and cognitive health. And today we have around 1,600 people that are registered in our registry. And we provide them with different kind of information around dementia prevention, brain health, also the activities at our center. And we send out a newsletter several times a year, and we are present at various events in the broader Cologne region to promote all our activities at our center. So the registry is free of charge, and at the moment it is limited to the, I would say, broader region of Cologne. And it's very important for us because the registry is the main or the primary recruitment platform for everything in the Alzheimer Prevention Center, for the recruitment of participants, for everything we offer. So I will show you here the personal expertise of our team. So we are an interdisciplinary team of psychiatrists, psychologists, psychotherapists in training, neuroscientists, and also student assistants. And we have expertise in with a focus on psychiatric disorders, but also memory disorders, neuropsychology, and psychotherapy, and also with the conduction of trials with healthy people and with people with subjective cognitive decline. And what is maybe special also is that the majority of our team members have or are certified course instructors for generic prevention courses that are covered by health insurance. And I will go into detail on the next slides. This is, by the way, you see on the right side an example of the newsletter we send out every couple of months. So we, in terms of activities, Frank Jessen already told you or introduced you to the Inspiration study, the study on individual risk profiling for Alzheimer's disease and dementia prevention. So I won't go into detail here, just 2 sentences because it's important for the next slide. Within this cohort of 160 healthy people from our registry, we saw that one of the most common risk factors was Western diet. And what we saw when we had a look at nutritional biomarker is that there is a correlation of a more pronounced Western diet and a higher omega-6, omega-3 ratio in the blood. So this was one of the, amongst others, starting point for a now ongoing feasibility study, which is the omega-6, omega-3 ratio in dementia prevention, a diet modification study, where we developed a 10-week dietary program to change the diet in order to reduce omega-6 intake and increase omega-3 intake. And we will pilot it with 60 healthy people from our registry that follow a Western diet. And the primary endpoint is actually the change or the reduction in the ratio of the 2 fatty acids in the intervention group compared to the control group. So this is actually an intramurally funded study. It's part of the CCAD, which is an institution at the University Hospital of Cologne. We have some previous experiences in terms of personalized prevention. So one is as a collaboration in the SCD well study, which was part of the larger Medit Aging project, where we have been involved in the study on mindfulness-based stress reduction versus health self-management in SCD. And also in a JPND funded study, Euro SCD, where we were part of an evaluation of an online lifestyle program for people with subjective cognitive decline. So an ongoing study, Federica introduced the PRETAT study, where we amongst others, focus on risk communication, how to better communicate risk in healthy people. So we have scenario-based assessments of expectations, needs, and preferences of healthy people at increased risk for Alzheimer's dementia. And you see that it's a really large assessment with a lot of healthy people. And the general aim is that we would like to develop a framework and a guidance for communication and for risk communication and also for counseling in predictive dementia risk estimation in preclinical stages of AD. And actually the idea of PRETAT was evolved during a previous study. Okay, so the previous study, PREDAT-QUAL, I will shortly introduce. It's actually a study on MCI patients, so the CSF-based dementia risk estimation in MCI, and what the effects of the dementia risk estimation is on several psychosocial outcomes. And also an aim of the study was how to better communicate the dementia risk. So the idea of this preceding PREDAT-QUAL study, we wanted to further develop it and to develop a protocol for healthy people as well. So in our center here, you see the picture of our group activity room, and we offer brain health courses or health courses for healthy people that are interested in dementia prevention. So we have generic prevention courses that are partly covered by our health insurance system, but it's mandatory that the trainers are certified, and these are not brain-specific courses, but they are courses for stress reduction, for example, so progressive muscle relaxation, mindfulness-based stress reduction, healthy lifestyle courses. And in addition, we do offer cognitive training courses, which are self-paid by the participants. So we try to summarize our plans to the 5 main points listed here. So one is, I think very important, is that our prevention office expand to a broader public. So it's mainly at the moment, it is really concentrated on the registry participants. Secondly, we would like to offer clinical trials or more clinical trials for asymptomatic people at risk of cognitive decline, including also pharmacological approaches and personalized multimodal interventions beyond the, for example, just presented nutritional study, which is ongoing at the moment. And then development and finalizing the disclosure and counseling protocol for people that are cognitively healthy but at increased risk for dementia. And then finally, as we all know, it's really challenging to maintain a healthy lifestyle, or it's even more challenging to change your lifestyle, especially when you feel healthy or not sick at all. So we think it's important to develop a program that is informed by techniques of coaching and motivational interviewing, targeting cognitively healthy people at increased risk, for example, SCD plus AD pathology, to enhance their competencies and motivation for risk reduction, for better adherence in trials, and also to increase their literacy on brain health. So we, of course, have several obstacles. So I think one main point is no coverage, no health insurance coverage for diagnostic and treatment in the context of dementia prevention. And this leads to, the restriction to third-party funded research projects at the moment. And insurance coverage actually will need a high level of evidence for efficacy in the context of brain health services, such as, for example, conversion to dementia or mortality. So here's a listing of the funding possibilities we have. So major part intramural funding from the University of Cologne, public third-party funds, industry funds, and philanthropy, mainly by the Cologne Association for Mental Health. This is our team at the moment in the Alzheimer Prevention Center in Cologne, and thank you very much for listening.
Thank you very much, Aida. Questions? Everything was clear? Okay, if there's no question, Aida, thank you for your presentation. And we move on to Oriol Grau Rivera from the Barcelona Beta Center. Oriol.
Hello. Good afternoon, everyone. Thank you very much for the opportunity of being here. I'm really enjoying here listening at this experience, and very happy to be able to share our experience, which will be focused on the Barcelona Beta Dementia Prevention Research Clinic. And this is a pilot or a proof of concept study that was launched 6 years ago by our former scientific director, José Luis Morinuevo, together with Karin Fauria here present, Carolina Minguillón, and others at our center. And this pilot experience was focused on identifying SCD and MCI individuals in the general population, communicating the dementia risk, and providing them personalized counseling and offering research projects. So this was a pilot study, but that ended 2021, and now we are trying to move forward to set a permanent BHS in our center. So that's what I also would like to show you. So our environment, this is our center. So for this project, we recruit people from the general population through a web-based algorithm. to ensure that they fulfill a minimum set of criteria, namely being 60 to 80 years old, having cognitive complaints, not having dementia, and not being followed up already in a memory clinic. So in our center, we have a neuroimaging platform with a 3 Tesla scanner, wet lab, fluid biomarkers lab, where we can do CSF and blood determinations, and a clinical research unit with a multidisciplinary team, and we have spaces for doing the medical visits, and also an infrastructure and a facility that is equiparable to a day hospital, like you can see here, here, where we can do lumbar punctures and also administer biological therapies. So we are very close, 5 to 10 minutes walk to Hospital del Mar, and we have a tight relationship with them. In fact, many of us visit there at the memory clinic also. I have, for instance, a double affiliation with the BBRC and with the Hospital del Mar. And there's also a clinical research cohort there named the Biotech Mar cohort, which was set by Dr. Albert Puig and his team, and comprises over 300 patients that have been characterized with CSF biomarkers. We also have a tight relationship with the Hospital Clínic de Barcelona, where we do our PET scans, and we have expertise in at-risk cohorts of cognitive learning impaired population, and we have participated or are participating in several European consortium projects focused on AD biomarkers and AD risk and AD prevention. And we have also experience in multimodal intervention since we collect the PENSA study together with Professor Rafael de la Torre from Hospital del Mar Research Institute, which is a study where we test a multimodal intervention supplemented with a green tea component to test its efficacy to prevent cognitive decline with very promising preliminary results. And we have also participated or participate in different disease-modifying drug trials. So here's the patient journey, or in our case, the participant journey, because these are all research participants. So we screened nearly 1,700 persons that were registered at the web-based system. From them, half of them were potentially eligible for our study, and we saw in person at 306 participants that were visited in our center, and they underwent a baseline visit where they underwent a visit with a physician, a nurse, and a neuropsychologist, and also they underwent blood testing and MRI acquisition. Then with this information, we calculated their estimated percentage risk of dementia in the upcoming 5 years based on an established algorithm that uses epidemiological data. And then in the next visit, we did the disclosure of this. So we communicate their risk, and we offered them a personalized counseling based on their individual risk factors. 1 week later, we assessed the emotional impact of the disclosure. And at 6 weeks, we invite them to our center. We offered them research studies based on their on their profile. Again, we assessed the emotional impact of disclosure, and same we did at 6 months and 1 year later at the end of the study. So we are still analyzing this data, but as some main outcomes, 90% of the population were SED, 10% were MCI. Here I'm focusing on the SED population, in which we are analyzing the impact of the disclosure. So this is the baseline characteristics: mean age 66, predominance of women, highly educated, and we divided them into low and extreme risk groups, low risk and high risk, to better analyze the impact of the disclosure. And as a result of this analysis, we found that, as you can see here, the high-risk group had higher scores, slightly higher, but significantly higher than the low-risk group in terms of the test-related scale. So the impact of the disclosure using the IGT-80 score, which is a test-related stress scale, and this was present along the whole study. But there were no differences in terms of the depression or anxiety symptoms across all the study visits, and the average values of these scales were always below the clinical cutoffs for depression and anxiety, which suggests that overall the disclosure is rather safe in this population. So here I would like to focus on where we are and where we would like to be in the upcoming years in this roadmap for the deployment of BHS. So stage 1 represents where we come from. This is this dementia prevention research clinic that I just showed to you. But this was an experience that was completely framed in a research setting at our center. And now we're moving to a different scenario where our direction board, together with the direction board of the hospital and its research institute, are trying to merge to integrate the clinical and research activity across these centers so that we can be able to cover the complete spectrum of the disease, and we can be better prepared for the arrival of disease-modifying drugs, since we, by joining our efforts, will be able to gather the necessary expertise, facilities, and to target the adequate population for this type of new therapies. So it's in this context where we would like to implement this permanent brain health service, and by leveraging our expertise in biomarkers assessment, in risk disclosure, and in dementia risk prevention. So these are a couple of examples of what we're doing or plan to do in this context. We are just starting a project led by Dr. Marc Suarez Calvet to validate the use of blood-based biomarkers in the hospital, and we are also applying for grants to do new studies to test non-pharmacological interventions based on nutrition, and also to test, try to demonstrate the cost efficacy of the multimodal intervention that we use for the PENSA study, and to try to reach out underrepresented or more low-income population with this type of interventions. So that's ongoing, and that's where we would like to be in the next stage. So we would like to set a permanent infrastructure, what we could call a BHS core, where we would evaluate any given patient from the hospital or participant from our research cohorts, or anyone that comes to our door, and perform a personalized risk assessment, do a basic personalized counseling, and offer also cognitive stimulation, and offer them, depending on the profile, individualized research options. And the idea is to use the evidence coming from our own research or relevant advances in the field and implement this in this BHS score so that we can iteratively improve the standard of care of the brain health service. As a final stage, or more long-term ambition would be to become a reference center in our environment, or a case study for the deployment of other brain health services across our public health system, and to be able to transfer this knowledge to the primary care providers so that they can implement primary prevention programs, and also, once secondary prevention treatments become available, to implement screening of the screening programs for the general population with blood-based biomarkers. So we have several limitations. Some of them are quite specific to our particular model. For instance, putting together or trying to merge the activity in an academic center like ours and a hospital is not easy. There are many administrative and legal requirements that are being worked out by our direction boards. So this is ongoing, but there's still work to do. And it's particularly challenging to integrate research and clinical and the clinical routine, since we have very limited time and spaces for doing the routine clinical visits. So we cannot just fit a brain health system there, but we need to create a complementary circuits, complementary schedules to allocate all these new activities that we would like to add. Also, we need to integrate the data systems, the IT systems from both centers, because we are in separate buildings. We want the systems to talk to each other, and we need to harmonize the way we collect data and we process the data across the centers. All this, of course, needs funding because we will need more personnel. We need to implement new procedures, and we also need to do more research to prove cost efficacy of this type of of this type of programs in order to convince the authorities to also fund this type of initiatives. So finishing with funding, so this particular project, the Barcelona Beta Dementia Prevention Clinic, was funded in part by a private company, Biogen, also by an agreement with the Barcelona City Council, and by our own structural funds of our institution, the Pascual Maragall Foundation. For this study, we offered to participate mainly in three big studies: the AMIPA study that was funded by IMI funding, the PENSA study that was funded by the Alzheimer's Association, and a clinical trial sponsored by a pharmaceutical company. And in order to sustain, to set up and sustain the BHS, we rely on our own structural funding, on this agreement with the Barcelona City Council, on competitive grants that we are applying and will continue applying, and also we'll try to do our best to convince our local authorities to also invest in this type of programs. So thank you everyone in my center, BBRC, and at the Hospital del Mar that have been working on this. And thank you very much to the audience for your attention, and I'm pleased to ask any questions you may have.
Thank you. Thank you, Oriol. I believe that you pointed to an issue implicitly, to an issue that most brain health services will have to deal with: the interaction, synergies, boundaries with currently active memory clinics. Mm-hmm. I'm going back to the comment that I was making to Mia. The MCIs, for the MCIs, we already have a pathway, a patient journey in current memory clinic. Of course, there will always be some passage of patients from the traditional memory clinic to brain health services, and vice versa. But setting, clarifying with the priorities for MCI patients, I believe it's paramount, because we should avoid creating competition between brain health services and memory clinics. No, you Mr. MCI, you come to us. You come to us. We're better than brain health services are better than traditional memory clinics, or vice versa. How do you? Because you mentioned also the use of that you want to get ready for the use of antibodies. But this is the domain of the traditional memory clinics. It's nothing new. Well, it will be new, but it grafts onto a patient journey which is already there. Mm-hmm. So how do you plan to interact with the traditional memory clinic in Barcelona?
The case is that our aim is not to have like two separate units, let's say, but to be a single entity that covers all the continuum. So some people maybe will go to the hospital or will never come to the BBRC building, let's say. That's where maybe all these complementary things that we're not doing at the hospital, like doing this more personalized counseling or engaging them in preventive activities. So sort of things that are not done in the hospital, and that maybe are people with SCD and maybe some people with MCI would benefit from, that could be done at the BBRC, let's say, at the research part, that where we have done the research, most of the research activities so far. And there are other people that will just follow the usual path in the hospital. But the idea is not to keep those things. Even if we do some things in a building and some things in other, the idea is that these are not two competing entities, but the same entity, and everyone can have an individualized itinerary depending on their needs. Some people may go to the brain health service BBRC, some people maybe come back to the hospital, or vice versa. Some people maybe are initially attended at the brain health service, but we find out that they are MCI, they can benefit from biological therapies, then go to the hospital. So it's like communicating glasses. But
okay. So the challenge will be to develop a coherent patient journey for the different patient types. We have time for one question from the audience, maybe. Mia?
Yeah, just back to this question, is for both of you. I really think this is an important point what you are highlighting. We should not create new silos. So we should really think the comprehensive patient pathway, whatever is there, and how to have the interaction between memory clinic and brain health clinic. As I said, we have it in the same unit, but two different kind of partly overlapping different entities. And I'm also thinking the patient is not always clear cut from SCI to MCI. MCI is very heterogeneous. Only part have amyloid and tau. What do we do? How long time we can follow up the rest, and how prepared the current memory clinics are to take care of the other factors? I think this interaction will be very, very important. And as you say, the research unit and hospital, the admin, legal, it can be very, very long processes there. So these are some things to reflect on.
I just wanted to add to that. When you have an MCI patient being cared for by the memory center, then maybe they can take care of the anti-amyloid therapy and the symptomatic therapies when they progress, but they don't understand or don't have a comprehensive approach towards multimodal precision medicine-based lifestyle interventions, which is critical in the earliest phases of MCI. So to me, if you separate it too much, or if they just go one place or go to the other, they're not going to have comprehensive care, and that may impact quality.
Absolutely agree.
Yeah, makes sense. On the other hand, how healthcare is paid also makes a difference. Now, the patient journey in memory clinics is funded by the regular healthcare. The patient journey in brain health services is not. So once they will be both paid for by the health services, well, of course, you can have in the same institution, in the same environment, with the same team, same personnel, you can have different patient journey. But as long as there's no agreement on the funding, I believe it's a useful intellectual exercise to consider them separate. Then ideally for the patient, of course, the more integrated they are, the better. Thank you, Riol. Next presentation is from my friend, another friend, Visje van der Vlier, scientific leader of the memory clinic in Amsterdam. Visje.
Thank you, Giovanni. And thank you for inviting me to this wonderful day. And I was discussing with some of you that sometimes you are at a day and then only when you're here, I realized, oh, progress is being made as we stand here. So I'm really excited to be part of this. So I am going to talk to you about the Alzheimer's Center Amsterdam, how we organize things, and about the science project. Because to be honest, we don't have a separate unit which we call Brain Health Service. But I do think that what we are doing very much relates to this concept. It is our vision that we really try to make a difference, both for today's patients by providing best possible care, and for tomorrow's patients, because every time and again we realize we simply cannot do enough yet. So we have a special focus on dementia with an early onset, but particularly relevant for today is that it is our vision that patient care and research should go hand in hand. Here, very briefly, the Amsterdam approach. So this is the patient journey part. So all patients visiting our memory clinic are seen in what we call the day screening. It's a one-stop clinic, one day. It's multidisciplinary and standardized. Patients see the neurologist, the specialized nurse, neuropsychological investigation is being done, MRI, EEG, lab, and we also offer lumbar puncture to all patients. And on this same day, we ask their informed consent to use the medical data we obtain anyway for research purposes and also for storage of their biomaterial. So the setting is a tertiary setting. We are an academic hospital and we get some referrals via GP. Self-referrals do not exist in the Netherlands, but most of our patients come via for second or even third opinion. And important when you look at the pie graph is that a substantial proportion of these patients actually have subjective cognitive decline. And after the visit, we actually invite them, all patients, for additional studies. And in case of the individuals with subjective cognitive decline, we invite them to be part of the science project. And the science project, which stands for Subjective Cognitive Impairment Cohort, by now has over 400 individuals who presented at our memory clinic with SCD. So they had by definition normal clinical investigations. So there was no MCI, no dementia. And we offer them an elaborate workup at baseline, some additional testing, additional questionnaires, also on lifestyle and other factors, and also including their amyloid status. So we had CSF, but we also offered them amyloid PET as part of the science project. And we follow them up for years. So in fact, we say to them, we reassure them, the neurologist reassures them there's no neurodegenerative disease at this moment. You can go home reassured. But then we say, can we now invert the question? Can you help us solve Alzheimer's disease? Because together we aim to discover the earliest changes leading to Alzheimer's disease. And actually this year, the science project exists 10 years. So we have a celebration. So the participants are what I like to call partners in crime. And I think the research we are doing here is really to prepare for the care of the future, because there's so many unanswered questions, and this is what we also realize today. So this is what it looks like. There's a diagnostic workup of the Alzheimer's Center, where we ask informed consent for the clinical data in the biobank. Then at the end of the same week, we have the multidisciplinary meeting where a diagnosis is being made, in this case of SCD. And there's also the science desk present, the research desk, and that checks, is this patient eligible for additional studies? And in this case of the SCD patient, they are then invited to the science project. And so we're now making actually the step from patient journey to research project. But the fun thing about the science project is that it looks exactly like a clinic, only it's research, and the participants know that. So they have annual visits. We also follow them by online questionnaires, and biannually, every second year, we collect biomaterial, blood, and also CSF if possible. And we have PET scans, amyloid PET, but also for a number of them, tau PET for many of them. And the beauty is, and I heard that in some of the earlier talks, but not all, that these participants are really motivated to help research. So we also use them as a research-ready cohort, and many of them participate in other additional studies on nutrition, on music, on tau PET or other PET studies, whatever. So to date, we have 450 participants. We are in our 10th year. Somewhat more females than males, 63 years on average, and roughly 1 out of 4 is amyloid positive. And here you see some of the research results. We learned from them that when you're amyloid positive, you're really more likely to progress over time. We can also show this in blood. And we also recently looked at the information we can get from their complaints, from the severity of their own complaints, and see that that actually behaves differently in the ones that are amyloid positive than negative. So in terms of where we are in the brain health service pillars, risk assessment, of course, in the patient journey, part of the routine workup is ApoE in our center, as well as lumbar puncture, and of course, the normal cardiovascular risk factors, blood pressure. And in the context of research, we also make an amyloid PET. And actually, the results of these tests are shared by the neurologist at the discretion of the neurologist. But I think nowadays, also now that patients have access to their own patient electronic health record, they can see all the results. So the neurologist also shares what has been found in terms of biomarker findings. And then we look at risk communication. Actually, we made this amyloid PET when we started that study. We said to the patients, participants, we don't share the results because we're studying what they mean. We don't know what they mean. But whilst we were doing the study, an increasing number of participants asked for their results. Then we said, okay, then we turn that into a study. So we study how to communicate about the amyloid PET result, to see what their understanding is, what the emotions are in reactions to the disclosure of amyloid PET and their experience, with the ambition to develop a best practice for how to do that in such a population. And the early findings are, in fact, that it's safe to do so and that patients are happy with it, and that whether they're amyloid positive or negative, they do not regret that they received the result. So that's an important result of this study. In terms of personalized prevention, actually in our memory clinic, there's only very generic lifestyle advice, and also the science project was not set up for this. But we're very happy that we have a grant in place that allows us to start personalized prevention this year. It will be an integrated lifestyle to study implementation of personalized lifestyle advice and also cost effectiveness. And patients with SCD, but also MCI, will be referred to a lifestyle coach where they have a coaching moment, also get access to an online lifestyle program and get vouchers to actually improve their lifestyle in the local gym. And I'm very happy that we're going to see how this works. And another example of how the research can actually drive what the care should look like. Cognitive enhancement, I put here not applicable, but that is not true, because when I listened to Giacomo Koch's presentation just now, I realized that we are also starting up this year, that's my colleague Willem de Haan, a study on transcranial magnetic stimulation in this population. Very excited to learn about that as well. So towards the future, I think we're all heading here as we stand here towards a future where we stop the Alzheimer's pathology before the onset of dementia, which is prevention. And I think that information to guide choices is key, that biomarkers will be very essential throughout the patient journey for prediction, diagnosis, prognosis, and also monitoring, so that we will have these tailored prevention strategies, making use of e-tools where possible. And I think that's also really crucial when we think that we have all these additional ambitions that we have, all these additional clients or patients that we will attract, how to keep this accessible and scalable. E-tools, e-platforms will be crucial. When I now look at the map, in terms of population, so we look at its research populations now. So cognitively normal, SCD, but for example, also EPAT is an important cohort at our center. Assessment of risk. Well, actually, we need to do better because the models in the cognitively normal individuals are just not good enough. So we need better prediction models. A lot of research work to do. Risk communication at the discretion of the neurologist, and studies on personalized prevention and cognitive enhancement soon to start, and really very excited about that. So this is, I think, an example of how we use research as the route towards improving care. And that I think it's really important that the interventions that we offer are evidence-based. And it's something that, particularly in the Netherlands, people are very keen on. And I think that the implementation of the disease-modifying treatments will actually propel the field forwards and will make this whole brain health service fly in the next years. So hurdles that I see are the lack of evidence, for example, the accuracy of the risk predictions, the effectiveness of the interventions, lack of insight and cost effectiveness. How are we going to do this? Lack of best practices, but as we are sharing this here, that's a great way to start. Also the fear of change that I see. Well, we've always done it like this. Why should we change? And the fear of medicalization. Who was a citizen before is now perhaps somebody at risk or a patient. And then the financing. So unless, I think almost all the examples that I heard did not mention health insurance. And I think that unless there's reimbursement, this will ultimately not fly. And then time. Everybody is overburdened already. So the system doesn't need more patients, but less. So how are we going to do this? And I think that patient empowerment and that people can really do something themselves is crucial. Funding, multiple fundings like research fundings for the science project. And I think for the future sustainability, we really need to come up with something smart. And with that, I would like to end.
Thank you, Fische. Any question from the audience? Mia.
Thank you, Jesse, for a nice talk and really highlighted the value how science can and should form the kind of clinic and what we are doing, the clinical practice, and how that can go hand in hand. For example, the example about the disclosing APOE or PET findings. So I think these kind of findings are very, very relevant if we can implement them also. So that's good. So it was just a comment that I like the pattern thinking of.
Thank you. Thank you.
Thank you, Mia. We have time for one more. Richard.
Great talk. You said that the clinical care would be provided by neurologists. Are there multidisciplinary experts that will be worked in, or is there going to be training for the neurologist? What is the plan there?
Let's say, so the Alzheimer's Center is based at the Department of Neurology. So in the Netherlands, you also have a lot of geriatricians that had memory clinics. So this was really the local situations, and a geriatrician could also do that. And then, of course, in the multidisciplinary team, there's also psychologists involved, radiologists. So there's a lot of people involved. For the lifestyle intervention, which we are not doing yet in the Alzheimer's Center, but are soon to start. We actually, in the Netherlands, there's from the government also a big push for lifestyle, not only for dementia, but in general. And there's what I think translates to lifestyle counters being set up in every hospital. And we're actually going to collaborate with them. Very excited about that, because I noticed that neurologists don't think that lifestyle advice is part of their job. And I think it doesn't have to be, but they should be able to refer to somebody else. So we're going to collaborate with these lifestyle counters where they have lifestyle coaches. Yeah.
Thank you. Valentina, last question.
Just a very quick one. The old scheme could work if we think that more patient now or more patient in this phase will mean less patient later. What do you think about it? Will it work?
Ultimately, yes, but it will take some time. So yes, indeed. And even if I put on a lot of hurdles, I really think that we should move forward in the disease. So I'm a big proponent of that. Also, what I did say is that I think these brain health services, they attract a crowd that is very much willing to contribute to research. And I heard actually, so we talked about lifestyle, but I think many of these individuals would be interested to participate in trials, also of disease-modifying treatments as well. And finding enough participants is actually one of the largest hurdles in research. So in this way, it might even further accelerate the journey towards actually solving this disease by attracting a larger crowd to help.
Yeah. Thank you. Thank you, Vishe. Time to move on to the next presentation. Federico Pozzi from Monza, who's working with Carlo Ferrarese at Ospedale San Gerardo and University Bicocca.
The pointer. Oh, okay, and it works like that. Okay, thank you everyone, and thank you for inviting me. I will talk briefly. What? Okay. No, I will talk briefly about our experience, our pilot experience in Monza. By the way, this is the Monza Park. It's the only place in Monza that's worth visiting in case you are nearby. Anyway, and so basically we set our experience within the San Gerardo Hospital, which is a public hospital. It's actually a research hospital, and it's the reference center for the Monza province, which is northeast of Milan. And the personnel that is now working in our brain health service is composed of 2 neurologists, me and Dr. Cuffaro. And there are also 2 neurology residents that are learning, let's say, and helping in our brain health service. We have a 3 Tesla MRI, the availability of CSF and soon blood biomarkers, FDG PET, and unluckily we don't have amyloid PET yet, but there are talks ongoing, and a neuropsychology department. And we started with referral through the memory clinic, as this was a project nested within the memory clinic of the San Gerardo Hospital. And right now we have promoted some educational projects with general practitioners. So we also accept referrals from them, from the general practitioner of the Monza province. And we also allow a sort of self-referral because we advertised on newspapers, and we had some press coverage for for the inception of this pilot experience. So people send us emails, and then we evaluate whether they would be suitable for a first visit in our clinic. The expertise is on dementia, neuroimaging and biomarkers, and movement disorders, and we allow 5-6 hours weekly for this experience. And this is basically the flow of patients in our memory clinic. So we used to care only about the left part of the slide. So the memory clinic now with patients with subjective cognitive decline go through the brain health service in which they have a risk assessment with lifestyle scores and optional use of biomarkers, also depending on several considerations that we made later. And we perform risk communication, and then we decide whether there is the need for further exams and the need for tailored multidimensional interventions. And we also have the possibility to enroll patients in research. And this is an overview of our sample so far. So we have seen 51 people. And as you can see from the map, most of them come from the Monza province, and a few of them come from nearby provinces. And the age is basically 67, but there is actually a huge range, and they are mostly more educated than the average users of memory clinics. So the average users of memory clinic in Italy, at least in the Monza province, has maybe 5 to 8 years of education. These are people who have high school education. So there is also a different perception of risk and willingness to be involved in prevention. They are mostly female and mostly driven by either a familial history of dementia and an interest in trials, so in clinical research. Up to 90% of them are interested in participating in research, and we have enrolled a quarter of them. And there are also subtle difficulties with aspects that in memory clinic we tend not to consider usually, such as finance management or the use of devices. So we also have to consider that in Italy we don't have like a very high digital education. So, I mean, these are aspects that are easily lost by people with subjective cognitive decline and can cause a bit of discomfort in their life. So, and most of our sample is comprised of patients with subjective cognitive decline. A few of them have functional disorders. So in the context of depression or something else. And very few of them are MCIs, and these are probably wrong referrals when we think of the scope of the brain health services. So we redirect them to the memory clinic. We use a template in which we analyze subsequently all the factors listed in the Lancet Commission, plus sleep. And we also apply the CAIDE and brief dementia screening indicator based on age and their limits of applicability. And if they are MCI, we use ADAPT that was developed at Amsterdam. And we have developed this Shiny app as a calculator for these scores. And this is the prevalence of the risk factors in our cohort. So, well, as you may know, the Pianura Padana, which is where we live, is one of the most heavily polluted regions in Europe. So, I mean, I just put 100% in terms of air pollution. I mean, there was no need to assess that with further. But anyway, most of them anyway report physical inactivity as the most consistent risk factor. Also poor sleep, which is highly prevalent. And most of them are also have hypertension, and they have some mood disorder, which is not always depression, but is there. And we don't know if this is caused by the subjective cognitive decline or is a cause of the subjective cognitive decline. So there is also a role for reverse causality in this sense. And also half of them are socially isolated, and also half of them are or have been smokers. And We perform risk communication following the guidelines provided that we heard this morning, and in terms of adaptability to the Italian context, sometimes we need to dichotomize risk because people don't really understand the numbers. So we need, in the end, to say this is low risk or this is high risk, because they don't seem to comprehend what we have just told them. And it's also difficult to benchmark risk because there is, at least in our province, it's not really that easy to benchmark risk. So people don't have the attitude to think about risk. And this may be inherent to Italian culture, but I don't know. And we actually do not require, it not seem to be required, psychological support, which seems in line actually with the data provided also by Barcelona. I mean, that providing communication about risk doesn't really result in negative emotional consequences. And so this is what we do in terms of personality prevention. As for now, we don't have structural interventions in place, but we are talking about it, and we have been having discussions with association, but I'll inform you about it later. So we proposed, we do counseling mostly about physical activity following the WHO guidelines. We have, we suggest following a healthy diet, and we refer them to nutritionists. Of course, it's out of pocket expenditures by the patients, but we managed to have some discounts for referral, and we also refer them for cardiovascular risk factor control and correction of hearing impairment, sleep counseling, and for socialization and cognitive stimulation, we tend to include them into research project in which they can have both. And in terms of further exams, we tend to prescribe only MRI in half of the patients and other exams in a third of them. And in terms of preventive intervention, we have seen that the principle is to, as Professor Kivipelto was saying, start small, because I mean, we want them to adhere to the intervention. So we do not always prescribe a multimodal intervention at the beginning, but we want a build up of that. So we in a third of our sample, we started with a monodimensional intervention based also on the people preferences. And as for cognitive enhancement, and I asked Andrea Borowski-Guevara before if that qualifies, we don't have a structural intervention so far, but we have a trial ongoing, which is the Cognichess trial, which combines the socialization and the cognitive stimulation with board games. And so we randomize them to either chess or Go, which is the one on the left, which is a very nice game if you want to play. It's really hard to understand, even if it has only 2 rules. And anyway, and it's going really nice. I mean, the patient that we have enrolled in this trial, mostly, I guess, also because they socialize, when they finished their cycle, they wanted to continue. So we had to open the possibility to continue in this trial. So, and regarding for now, we do not have the genetic testing, but we are implementing now that, and we are in the talk with the genetics of our hospital to implement an NGS panel, and we are soon to implement blood biomarkers in this population, at least for research purposes, of course. And we have, for cognitive enhancement, we are also in the talks to include TMS also for research purposes. And our objectives, anyway, extends further. So we have put in place some educational events with general practitioners. We have 2 of them at the end of the month, in which we explain them this new concept of brain health services and how to refer people to us, and what to tell people, and how to select the people that would be that would probably benefit from such a pathway. And We also want to involve nutritionists, physiotherapists, and psychologists. And we have been talking with organizations, with charities and patients' organization within the Monza and Brianza territory. And we have received positive response. So they are willing to help us for the output, basically, of our brain health service. So we want to send people to perform structured intervention with a protocol that we are developing now within the territory. And of course, the long-term idea is to include that in the Italian national health system offer once we show that probably it's cost-effective. But I mean, we have already been talking about it, so I mean, it's nothing new. The hurdles, I mean, at the beginning, we found cultural barriers, even among neurologists, because they were like, why do we have to do this? I mean, we already have the memory clinic, but well, 20 years ago, probably it was the same when there was the inception. I mean, I was a kid, but there was the inception of the memory clinic, and probably it was the same. There are always cultural barriers when we want to start something new. And we had some inappropriate referrals, mostly of functional patients. We were mostly depressed, so it was quite hard to make people understand, okay, what is subjective cognitive decline? And we, of course, anticipate that there will be a problem in adherence. And regarding funding, right now, well, it's paid by the hospital.
Federico, it was a message from...
Yeah, sorry. Yeah, no, it's the last slide, actually, sorry. Well, it's paid by the foundation, by the hospital, and and by research. So that's it. Thank you.
Thank you very much, Federico. There's just time for maybe one pressing question. Alice? Hold on. Now you should talk into the microphone.
Hello. Thank you for the presentation. I have actually two quick questions. The first one is on, you mentioned cultural barriers. So I was thinking whether you think that brain health services should also engage into educating like neurology trainees and geriatric trainees so that the next generation and maybe also this generation is ready for them. And the second one is with regard to, you mentioned like the population that you've seen is highly educated. Maybe they come also from like socio-economical advantages classes. So how do we engage with people who are minorities or maybe have collected risks? How do we get to them? And also, since those people get then less involved into clinical trials, how can we communicate risk with them?
Yeah, I mean, those are two points that we have been considered, and we have been talking about this. We plan to include people who are marginalized through the aid of GPs. So if we educate GPs first, and they have a grasp on the territory, on their community, then maybe we will be able to get referrals for people that are not usually interested in this sort of patient journey. And so I hope that the Brain Health Service mission will be also for patients, of course, but also for the community in a broader sense. So if we invest in prevention, I think we should not like live in a sort of ivory tower, but also get dirty and go to the territory and speak with people.
Yeah, I suspect that once we start in production mode, we will find that there's a large number of persons who are trying to kill themselves, basically, with all possible the worst possible risk factors, and they probably will need to have a journey, an approach radically different from lowering amyloid or doing transcranial magnetic stimulation. If you're smoking 60 cigarettes per day and you drink 2 liters of wine, even if it's Italian wine, you need something much different than doing even Giacomo Cox's super effective TMS. Thank you, Federico. We can move on to the next. Richard Isaacson from New York. He's come all the way from New York to Geneva for this meeting. Thanks, Richard.
Thank you. It's great to be here.
You will have 30 additional seconds.
30, yes. I can show the video. Thanks, everybody. So I don't know how to move the slides forward. I'll just vamp until I can figure that out. What do I have? Was there a slide? So, oh, there it is. Okay, great. Actually, let me head back a little bit. So I saw my first patient in a clinic outside of a research setting in 2009 at the University of Miami. So in America, we do things backwards. And basically, we started the clinic before we really even initiated the research. So I'm going to try to walk us through a snapshot of how things worked at University of Miami, how things worked at Weill Cornell in New York City, and then most recently. And I think, in terms of the crystal ball, we're trying to figure out what this will look like in 15 years. And the way that I'll try to give you a snapshot is to go back in time about what the last 15 years have looked like, because it's evolved quite a bit. So at the Alzheimer's Prevention Clinic at University of Miami, it was very unique. It was very confusing. And basically, I saw my patient with dementia, and then I saw their family members. And that's the Alzheimer's Prevention Clinic. I saw families, and we had residents and we had students, and it was a little niche clinic, and it was interesting. And then the phone calls started coming in for actually seeing the actual patients without seeing the affected patients. And that's what led to the beginning of the Alzheimer's Prevention Clinic. That was at Weill Cornell and New York Presbyterian in 2013. And that was both a hybrid clinical research program and clinic at the same time. It was 1.5 days per week. We had 2 physicians, both neurologists. We had a family practice nurse practitioner. We had multiple research coordinators, and we had over 30 consultants. This was in the early days when I was trying to care for patients, but I'm a neurologist. I don't know how to care for patients that have high cholesterol, and I don't manage blood pressure, and I don't do these medical things. I don't even know how to manage sleep. I'm a cognitive neurologist. So we had an entire team of people, and we would walk the patients through the journey, and I'll try to explain that. And then most recently, I've been with the Institute for Neurodegenerative Diseases. And again, things have evolved. We have a biorepository to assess biomarkers. We have a clinic, one in New York and one in Florida. And we've gone from the insurance model to now the self-pay model and everywhere in between. We've collaborated with a lot of people because in the learning phase, we had to learn a lot. And these were the people that were on our multidisciplinary conferences where we discuss cases, and that's how we learned how to care for these patients in real time. I think it's important to have some basic tenets when we're talking to patients when we don't have a cure and we don't have the perfect plan, and the Alzheimer's Prevention and Dementia Prevention book has not been written yet. Everyone in this room is going to help write that, thankfully. But we have to try to be as evidence-based as possible and safe. It's not one size fits all. It's not an algorithm. And we have to promise not to overpromise. And that's really critical. We're going to do everything we can. But in every publication, every forward-facing thing we show patients, no, you cannot definitively prevent Alzheimer's. And we were really cautious about that. In terms of a patient journey, we've tried different options. We basically can walk someone through where they make a phone call and schedule the assessments. And then every patient, before they sat in our office, had to complete multiple lessons about what Alzheimer's prevention is and isn't online before they could even basically come to see us. We did the studies, we kept going, and then had long-term follow-up. And the game board philosophy really helped patients understand this is going to be an ongoing relationship. And each place is going to have a different, journey here. But we have gone through, I think the red aspect here is critical. Having a consensus diagnosis with multidisciplinary experts that meet to discuss the cases is critical. Whether you're a busy neurologist or you're a psychiatrist or whatever your subspecialty is, when you're trying to develop these personalized plans, we had 5 things on the list, then 10 things on the list, and now we have 20, 30 things in our universe of things that we recommend. That was from the learning over a long period of time of case discussion with colleagues. We try to simplify it for patients. The approach we take is what we call now the ABCDE of Alzheimer's prevention management, and this is recently published. But anthropometrics, which meaning body composition, body fat, waist circumference, blood-based biomarkers, and that means actually nutrition markers, cholesterol markers, metabolic markers, inflammatory biomarkers, as well as Alzheimer's biomarkers in the serum, cognitive tests, both on the phone at home to in person, DNA, which we do a limited amounts of testing, and then emotional health and social well-being is critical, and we include sleep in that as well. In terms of creating that personalized plan, we have lots of inputs and then lots of interventions. If this, then this, and if this, then that, and if that, then that. And we've published on this with our methods papers. We take highly into consideration ApoE, but not all ApoEs are created equal. Whether they're homozygous or heterozygous, there's a lot of other things going on, whether they have a family history or not. What are the epigenetic factors? What are their vitamin D levels? Do they smoke? Mediterranean diet? All of these things need to be thought about differently depending on if they're E4 positive or negative. We use home monitoring. We have sleep devices and we have continuous glucose monitoring. And in the United States, these are common and patients can either pay for it for $100 here or they could get coverage by their insurance. So if someone has insulin resistance, we're going to follow them in real time at home, and we have apps to do this. In terms of demographics, the goal of this slide isn't to go into details, but I did want to mention, as we brought up earlier, that in the initial phase, 20% of our cohort was MCI. Did not plan that. That wasn't intentional, but when you have patients that are referred and they're fine, but then they're in your clinic, then they're your patient. Those 20% of the patients took about 80% of the work. So we have to be very cautious with that. The other part about this is while I bemoaned it, I'm thankful that they were in the initial studies, because then we can understand the differential effectiveness of our interventions, whether you're primary prevention, secondary prevention, or tertiary prevention of dementia. So in that sense, it was good, but otherwise I agree with eventually splitting it up is going to be critical. The good news is we got better, and in the most recent cohorts, only 12% have MCI, and that's gotten better. A variety of publications, can't go through them, but what we tried to do is every time we tried something, we would put the roadmap out and we would try to publish on it. So whether it was in a JPAD or most recently in Nature Mental Health, as our methods are developing, I think it's critical to share these, disseminate them, so obviously other people can reproduce them. And in terms of what our outcomes are, well, our outcomes are just like Dr. Dubois said, we need clinical outcomes and biomarker outcomes. And we had prevention groups and then the early treatment group. And what we did is instead of having a dose response, we had compliance. So did someone comply to an intervention? So we gradiate outcomes based on a variety of factors, demographic factors, compliance, et cetera. This is all published, but cognition, obviously, this is the Alzheimer's Prevention Cognitive Composite. When it comes to risk scales, we use 2 cardiovascular risk scales, 2 dementia risk scales as our outcomes. And then most recently, in terms of the plans for the future, this is my plan. My plan is to try to investigate on an N of 1 basis and step away from the aggregate, although I love the aggregate and the aggregate's important, but N of 1. So when we have a person that comes in that has these risk factors, I want to see how they do over time with the personalized plan that they get. And in N of 1 trials, in aggregate, in the submission we sent to AAIC, in aggregate, there are significant improvements in amyloid in the blood. C2N is the one we use, and also tau, p-tau217, the ALS path. We use these as surrogate markers. I think this is the future. You know, the cholesterol test, HDL and LDL, I think the cholesterol test of the brain is going to be these amyloid and tau markers, but not all markers are created equal, and different assays have different validity. And that's what we need to tease out. We're trying to, get as many assessments as possible. And we've been piloting finger prick assessments and basically using at-home blood spot card testing, and submitted another abstract to AIC. But I think the way to truly monitor patients in real time from home and bring costs down would be to democratize care if this is going to be valid. In terms of hurdles, I wish I had 10 minutes for hurdles. Find a way or make one. This is very hard. I have bullet wounds, and I am a broken man because of trying to push this forward. Between the lack of insurance reimbursement, criticism from your colleagues, insufficient research funding, slow translation of something that gets proven today, you can't start that in the clinic tomorrow. It's not accepted. The hurdles are great, and the only way that we've kind of gone forward is just to keep on going. When it comes to funding, 70% of our funds have been through philanthropy, 20% for grants, and then 10% of clinical revenue. On the average, we collect between 28 cents and 38 cents on the dollar for every dollar that we submit to insurance, commercial insurers in the United States or Medicare. And that's not a lot, but it's something. And that basically pays for about 10% of the costs. And honestly, if it wasn't for philanthropy and grants, the clinical services would have gone bust years ago. What we've also tried to do is we've tried to create coursework and educational modules for patients as well as clinicians. Some Mastering Brain Health course so people can learn, so it makes you more efficient. We've created coursework for high school students, college students, medical students, healthcare providers, including CME, neurology residents, and the public. Over 2.5 million people have taken this coursework, mostly public. And then we've studied this coursework in randomized trials, and you can check out JPAD or other journals to see the results. Finally, we're now moving towards digital tools, and this is an NIH-funded study of a digital therapeutic that will try to reach patients more broadly and more cost-effectively. Am I on time? We're good. Okay, I think I can end there. I was going to show a video of some patients talking, but it seems like y'all have seen some of these patients talk, so we can skip that. So high-yield links, please reach out for any questions. Happy to help, and I'm privileged to be here.
Thank you very much, Richard. To do is that you, Richard, you are in the environment where you're working, you're a hero. Because and this is the reason why Richard is the only American here in this meeting. You're working in a place in the United States where there's a large number of brain clinics which overpromise.
Oh, right.
If you want to develop your own brain clinic, I believe this will be one of the keywords. Yeah. Not to overpromise. We discussed that the book by Dale Bredesen. Richard works in an environment dominated by Dale Bredesen's book, The End of Alzheimer's Disease. And I also had patients coming with me saying, "Doc, have you read this? You should read this. It's a great book." Okay, and I say, "Of course, I will read it," and I did. And it's not funny reading. So I believe your advice not to overpromise is really something that we should take back home.
Okay. Thank you.
Questions? Frank.
So thank you very much. I mean, this is, of course, very impressive and probably like a role model where we want to be in the future. Just very practical question. How much time on average do you spend with a patient before you put him or her on this track? And how do you follow the adherence of all the advices you give?
Yeah, great question. So it's depending on the epoch. So let's start at Cornell. At Cornell, intakes, well, there was about an hour and a half of intakes before the person would come to see me. They would do about an hour of cognitive testing. They would do the InBody, which is basically a biometric thing, which takes 5 minutes. They would get their blood drawn. They would get their waist circumference done. And that was phase one. Phase two was they had to spend their own time, at least 30 minutes at home, taking coursework. And then once those two phases were done, they would come in to see us. The first several years, it was just me. And then we had a nurse practitioner. The nurse practitioner would basically, physician extender, spend an hour with the patient. I'm doing a kind of structured, very detailed neurological history. Then she would present to me, and then I would come, and then basically for the last 30 minutes, we would put together the personalized plan based on the prior evidence that had been collected and based on the clinical history. And so that's about 3 hours and change of contact time. Nowadays, it's very different, depending on the payer model. If someone pays more money and has wants to spend more time, we can spend hours and hours and hours and hours. And that is not an exaggeration. It could be 12 to 15 hours of contact time per person to create an individualized plan.
Thanks. The costs will speak for themselves. Yeah. I believe that we should move forward. Yes, sorry about that. I was mentioning 8 presentations, so you paid for 8, but you will have 1 for free from Paris online.
Okay, can you hear me? Okay.
Théo, vous
Oui.
m'entendez?
Yes.
Ok, allez-y. Bonjour Théo.
But
Vous êtes
I'm
en
not sure
ligne.
do you see my slide?
Ouais.
Okay, because I cannot see the
Allez un plein écran s'il vous plaît. And you can start your presentation.
Yeah, sorry, but I have some technical issue. Oh.
So what's... Ok, Théo, vous êtes toujours là? Théo?
Oui.
Est-ce que vous voyez votre propre écran?
Yeah, it's fine for me. Okay, I can start. Sorry. Hi everyone. Thank you very much for inviting me. I have a echo.
Vous devez, Théo, vous devez partager l'écran. Vous devez partager votre écran.
Oh,
Parce que nous ne voyons pas vos slides, vos diapos.
sorry.
Voilà, maintenant on les voit. Ah, clique, voilà, allez-y.
Yes,
Click,
but it's
click.
yeah, okay.
Ah,
I think it's
on y
fine.
est.
Sorry.
Go.
So hi everyone, thank you very much for inviting me and giving me the opportunity to share our experiences related to the prevention of neurodegenerative disease. I will continue this roundtable showing you the progress of our prevention center in Paris. And as we did not start piloting our project, it remains exclusively theoretical. Sorry, but I have an echo of myself. But I will continue anyway. My slide doesn't change. I don't understand why it's not working. I'm so sorry. Are you still with me?
We're here.
But my slide doesn't change. I don't know why. I'm so sorry.
Tell us your... Can you give us your presentation also without showing the slides?
Yeah, I can. Oh. Okay, so I can continue the slide.
You go on. In the meanwhile, we're trying to load your slides and show them from here. And you will tell us, go on, next slide, and so on. Okay?
Okay. So I'm a neurologist working at La Pitié-Salpêtrière Hospital in Paris, in France. And I'm working especially in the memory center called the Memory and Alzheimer's Disease Institute, directed by Richard Lévy and Bruno Dubois. This memory center is closely connected with other departments in the hospital, including the neurobehavioral unit providing cognitive disorder expertise at the crossroad of psychiatry and neurology. So we can change the slides. One more. The biochemistry laboratory, which is involved in biomarker measure. The neuroimagery and nuclear imaging department, enabling MRI combined with PET scan and amyloid PET to be performed for patients. You can advance the slide. One more. And the Paris Brain Institute, an important research pole in neuroscience directly located in the hospital. So this is in this environment that we want to develop a prevention center for neurodegenerative disease. You can change the slide, please. So to better understand the environment around our prevention center, it is essential to explain how the French healthcare system works. So usually when patients have a medical issue, they first need to see their general physician. You can move the slide, who assesses the need for referral to a specialist depending on the nature of the symptoms. You can move the slide. This procedure is required for patient in order to be reimbursed. So in our case, patients often see the general physician for memory complaint, subjective cognitive decline, or concern related to a family history of neurodegenerative disease. So consequently, the general physician referred patient to a neurologist for a memory consultation. So the initial assessment aims to detect if symptoms are suspected of neurodegenerative disease. If it's the case, patient continue the usual medical pathway in the memory center. You can change the slide, which is organized in the daily hospital, combining several approaches in order to propose a final diagnostic and often a combined medical follow-up with their general physician and neurologist. We can change the slide. In the other case, that is when the neurodegenerative disease is not suspected, no specific medical care exists in France, and in general, no medical follow-up is proposed for these patients. You can change the slide. Our prevention center takes action at two critical time points in this medical pathway. So first, we aim to use a digital tool called Santé Cerveau Toolkit before the memory consultation with the neurologist. So using an algorithm based on auto-questionnaire and auto-test assessing cognitive functions, this tool can distinguish a memory complaint suggestive of neurodegenerative disease from a more benign one with a high sensitivity and specificity. So it will help memory center to better orient patient in the memory consultation. You can change the slide. We plan to organize a new medical pathway involving the prevention center for patients with a more benign memory complaints. And the objectives are multiple and involve first to respond to a patient request, as a large proportion of consultation in memory centers do not reach systematically to a neurodegenerative disease and diagnostic, and because more and more individuals are worried about their memory. Second, to better coordinate, slide before. Thank you. Second, to better coordinate medical pathway of patients in memory centers. Third, to propose active and personalized prevention. And fourth, to contribute to the scientific research efforts to bring out innovation in the domain. Thank you. Here is a description of a typical journey we theoretically plan for patients. You can change the slide based on the 4 pillars proposed by the Lancet Regional Health article. You can change the slide. First, we propose an initial risk assessment during a daily hospital, including clinical assessments by a neurologist and neuropsychologist to rule out any suspicion of neurodegenerative disease, and a multimodal assessment of cognitive decline risk factor involving several health professionals, such as psychologists, dietitians, or specialized nurses. And the initial risk assessment can be completed by additional assessments requiring specific expertise, such as the intervention of sleep center, the metabolic center, the psychiatric department, or ENT physician. And we want to create and organize a hospital network that the prevention center will coordinate. Afterward, patients are seen in a specific consultation that aims to communicate the risk to the patient. Next slide, and propose a personalized prevention based on scientific evidence, such as the one proposed by, for example, the Finger article. This may involve physical, psychological, cognitive, and dietitian coaching, but also, next slide, involves the hospital network we want to develop for managing, for example, sleep disorder or hearing loss devices. Next slide. In addition, we want to develop a research network, scientific collaborations to identify, next slide, additional risk factors, but also, next slide, develop new prevention interventions. This research part of the project is outside validated guidelines and will be done on a voluntary basis. So considering the planning proposed by the Lancet Regional Health article, we are still in time to start piloting our prevention center. We plan to build a prevention center progressively with 4 critical steps. Next slide. The first step is currently to start piloting the project, but without introducing the Santé Cerveau toolkit. So the initial neurologist consultation will orient patients to either the memory or prevention centers. Secondly, we want to introduce the Santé Cerveau toolkit, which proposes the pre-screening of patients to increase the fluidity of the medical pathway. Third, next slide. We plan to extend the prevention center to other institutions in Paris and its region. Next slide. Finally, we want to raise awareness among general physicians about the risk factor of neurodegenerative disease. Next slide. It allows us in the future to recruit patients without any symptoms, but who have several risk factors detected by the general physician, for which we can propose an assessment and interventions. Next slide. Several challenges remain to be solved. So first, we can ask how to select and recruit individuals in our prevention center. How old should our patient be? Do they necessarily need to show memory complaints? And it leads to other questions. Next slide. In particular, how do we manage the overflow risk of our center? One answer is probably to extend the prevention concept to other memory center. Next slide. That's supposed to create a network within the current healthcare system, which is not so easy. Next slide. The second question we can ask is how do we get the hospital to agree to bring in people who are not sick in the hospital for prevention? So this point can easily justify because the project aims to respond to patient demand and follows public health policy that puts forward the prevention in individual medical pathways. It should also be essential to demonstrate our intervention efficacy and cost effectiveness for gaining hospital acceptance and autonomy. Another major question concerns the risk factor we should target. Depending on the publications in the domain, other risk factors have been highlighted and may be considered at several stages of life. Next slide. It also leads to major ethical questions. So how do we communicate to patient risks that are not yet modifiable by any intervention, and in particular genetic factor such as the ApoE genotype? Next slide. Concerning our funding, we have a different option. Our project is at the cornerstone of medical care and research, and we want to keep connection between prevention center, current memory, and research centers. Hence, we expected to receive public funding hospital. One option proposed by our administration is to start piloting our prevention center within the actual memory center, creating a new type of daily hospital. Next slide. It will allow us to validate the concept with scientific evidence and assess the cost effectiveness in order to progressively, next slide, make the prevention center an independent structure adjoining the memory center. Next slide. We also hope, that research funding will be grafted onto the project. We have ongoing research project that recently received fundings. We can also think about private, associative or public funding. And finally, we believe that scientific collaboration is another option to gain credibility in the scientific community and in our respective administration. Next slide. So I want to thank all the members of my team at the IM2A. And I would like to thank you for your attention. And I'm very, very, very sorry about this technical issue. I don't understand why it didn't work.
Thank you very much, Theo. In the end, you made it brilliantly. And we still have time for 1 or 2 questions. If I get it right, you're at a very early stage. You're at the planning stage. So you may be able to tell us more, something more concrete in possibly one during our next a future meeting of this community. Now we are at the end of this part of the afternoon. We are all tired. I see you're tired. I am tired. We're all tired. However, if you're interested in setting up a brain health service for the prevention of dementia, you will need money, you will need a business plan, you will need a business model, and I suspect that you may wish to stay and listen to Linus Jönsson's talk and the talk from the people from Deloitte. However, we were supposed to have a 45 minutes break. It's long. Yes, but we're in Switzerland. So I propose a referendum. Shall we cut by 20 minutes? No, Cristina, siamo in Svizzera, no, non si può, non posso decidere io. Qui si alza la mano. Qui siamo a Ginevra, siamo in Italia, cara mia. Who votes? Quando sarai tu a chairman, sono sicuro. Who votes for cutting the coffee break to 25 minutes instead of 45? Unanimous. Back in 25 minutes. Someone slightly more than that. Please take your seats. On y va. Okay, so while you take your seat, let me introduce Linus Jönsson. Linus is a health economist. He's a very rare animal in our field, a very extremely precious, someone with whom it's very easy to find neurologists in our community, to find psychiatrists, even geriatricians, but health economists, it's a really very, very seldom we have the pleasure to work with one. So Linus will give us an overview of the business case in Europe, or maybe generalized to Western countries, for for dementia prevention. Linus?
Yep. Okay, thank you, Giovanni. Do we have the clicker also here? Okay, so anyways, we've had all sorts of animals here, elephants and lions and health economists also here. So it's been a really inspiring and interesting day so far. I hope I'm not going to lower the mood too much now by starting talking about whether anybody will want to pay for all this in the end. But that's, of course, what we're going to talk about here. I will try to illustrate what could be a business case for dementia prevention. And I will focus on kind of the core aspect of a business case, and that's really what is the value that's being created by the service. Okay, of course, many other things you have to consider in a business case. So who is going to pay for this in the end? How are they going to pay for it, and why should they pay for it, and so on? But I'm actually going to start with what is the value that's being created by dementia prevention, assuming we can do it. How are those gains from dementia prevention distributed over different stakeholders? Of course, the main customer, if you will, is of course the person who's in the program, but there are of course other stakeholders that are important to consider in the healthcare system and outside. So how are the gains from a dementia program distributed? At what cost could a dementia prevention program be cost effective? So what could you actually charge for something like this if it works? And finally, also maybe something about the earning period. So if you make an investment in this, how long time will it take until you can sort of recuperate your investment in it? So those are the type of questions that I'd like to start to address today. I'll just start a little bit with what we know about the costs of dementia. I'm sure that many of you, or all of you maybe in this field, have seen this type of slides before. The total cost, if you just count how much do patients with dementia disorders cost society, it's about $1.3 trillion perhaps per year. We know also these costs are distributed differently depending on where you are in the world. If you're in low-income countries, it's mainly families who support the patients in terms of informal care. That's a resource that's being used. In high-income countries, it's kind of divided between informal care and social care. We have a little bit of direct medical care as well. You see here, about 16% in high-income countries. But most of these costs are outside the healthcare sector. Turning to Europe, which will be the focus of the presentation here for me, we know also that the costs of dementia increase as patients progress. Patients in severe dementia have higher costs than in mild dementia. This is consistent here across different regions in Europe, although the distribution of costs differ. You see in Southern Europe, there's more informal care, while in Northern Europe, in the Nordics, we have much more nursing homes, so we have higher formal care costs. So different colors of the bars here, but you can see that the heights of the bar is actually quite similar. The total societal cost is kind of very similar. One issue here is that almost all cost studies in dementia only focus on the costs in people with dementia. They don't consider that patients without dementia, of course, also, or people without dementia, of course, also have costs for care. And it's really the net that we're interested in when it comes to prevention. We've done one study here in Sweden where we compared patients with Alzheimer's disease with elderly matched by age and sex and region, but without any dementia. And we can see that if you have Alzheimer's disease, your costs will be shifted basically 40 years forward. Okay, so you have the same cost as somebody who's 40 years older if you have an Alzheimer's diagnosis. But of course, there is a cost also in patients or people without Alzheimer's disease, and it's the difference there that we have to consider when we're talking about prevention. Okay, so I'll say one more kind of methodological thing here. We also have, so part of costs, we also, of course, have health effects of prevention programs. And as health economists, we need to have a currency of health in order to be able to compare different ways of spending our healthcare budgets. And we are using typically QALYs, quality adjusted life years. It's a way of combining quality of life and survival. So if you have 1 year with a quality of life, let's say, or utility, we call it, of 0.8, let's say, then you get 0.8 QALYs. If you spend 2 years with 0.4 QALYs, in 0.4 in utility, you also get 0.8 QALYs. Okay, so it's a way we can calculate the transfer between quality of life and survival. It's not perfect, but it's what we have. If somebody comes up with a better method, you can be famous. We're happy to have improvements here, but this is what we're using. So I'll be using here like standard health economic methodology to analyze a potential dementia prevention program and see what comes out. Right, so here, just one slide also on what we know about the utility weights or QALY weights in dementia. So we know that in severe dementia, it seems that quality of life is impaired. We have to rely on proxy responders or informants, because when we ask patients themselves, we don't really get reliable estimates, of course. But you also see the standard deviations are very high in severe dementia. We know a lot more about the early stages. It seems also that in MCI, quality of life is not particularly impaired. It's almost comparable to cognitively intact individuals. So this what I showed you now is the data that I'm actually going to use for the modeling of cost effectiveness of a prevention program. To say a couple of words about modeling in an elderly population as well. This is something that many of you will be familiar with as well. You always have to factor in what happens to mortality. If you're changing disease progression, but really what matters is what happens at the same time with mortality. So if you have a prevention program in really advanced stage of disease, you're prolonging mortality, prolonging life at the end of this life, you will basically have a period where you have a really, really high cost that you're prolonging. And in that situation, you may actually have an increase in healthcare costs. Okay. On the other hand, if you delay the onset of disease, you're adding time, so to speak, at the beginning of the disease stage. You're shifting the whole morbidity course forward. And in this situation, you might have exactly the same costs as before, just that they happen later in time. Okay. And then finally, you might have a situation where you have competing mortality risks, so that you shift the disease course, and then the patient kind of dies from other causes before they end up in the severe stages. In that case, you actually might have a decreasing cost. So I just want to show this because just because we are delaying the onset perhaps of dementia, which is a costly condition, it doesn't mean necessarily that we're going to save costs. It depends on what happened with mortality and what assumptions we make. Okay. So I'm going to show you some results now, and the intention is to give you a kind of an intuition of how does this type of modeling work that health economists do, and what might be the value of a dementia prevention program, more or less. These are not exact numbers, but it will give you an idea. Oops, now we're going back and forth here. Okay, so this is the model I'm using. It's a fairly straightforward model. We are starting with patients, people cognitively unimpaired, but at risk, and then we look at their risk of developing dementia disorder and then progressing across these dementia states. We assume also that the prevention program will delay both the onset of cognitive impairment and also the delay to more severe states. So you have both those effects in the model. And of course, there's also mortality. We assume that the state-specific mortality will be unchanged. So that means that since fewer patients will end up with severe dementia, where the mortality is high, we will actually have improved survival by necessity in this model. That's what will happen. Okay, so these are some base case assumptions. I've deliberately chosen a quite conservative scenario, perhaps. We assume that we have an effect size of 20%, and we start at age 70 years, and this effect duration is in 5 years. And we are analyzing a population with a relative risk of dementia of 3 compared to a healthy population. So this is a very generic model. You can adapt it to any type of situation, of course. You can increase the relative risk to approximate a patient with ApoE4 homozygous, for example, if you put it at 11 or something like that, right? So it's a generic model to simulate prevention programs in different at-risk cohorts. So finally, we also have to assume a value per QALY, because we want to try to calculate the overall monetary value of this prevention. We have to choose and how much is a QALY worth. And I put it at more or less the average GDP per capita in Europe, which is about 31,000 euro also. And this varies, of course, what healthcare systems consider to be a reasonable value per QALY. In the UK, perhaps it's 20 to 30,000 pounds per year. In Sweden, perhaps it's 100,000 euros and so on. So this varies a bit, but this is some type of average, if you will. Okay, so let's look at some results. What is the value of a prevention program? So let's start with just looking at a distribution over these different disease states over time. So in the left, we have our prevention program, and to the right, we have standard of care. Okay, it's not dramatic. I can consent to that. It's of course a small effect. Most patients or most people here will never develop dementia, okay, and most will simply die. And then you have something going on there at the bottom, right, in terms of how many are in the different dementia states over time. So let's look at the differences now between these two arms. So what you see happens then is that the share with the difference in the share without dementia goes up as this intervention effect takes hold. So if we are treating or assuming that the program has effect for 3 years, you'll have an increase for 3 years, and then it goes down again, right? And you can see also that there's a decrease, corresponding decrease in the proportion of the cohort in the other states, in mild, moderate, a little bit in severe dementia, not that much, and then of course also in mortality. So there's the mortality benefits. We can look at this in terms of how much time you spend in these states at the end of the life. How much more time have you gained without dementia? And in our scenario here, if you assume 5 years treatment effect, you gain about 6 weeks. Okay, 20% effect over 5 years in the at-risk cohort with a relative risk of 3, you get about 6 weeks. This is fairly consistent. There are lots of different models like this. They show more or less the same results, right? If we increase the treatment duration, of course, we get more effects. It's pretty linear, actually. We can look at different starting ages, and it turns out that what really matters here is the absolute risk of developing dementia. So if you're increasing the starting age, that means that you have a higher risk, of course. And that means that we will get more time saved without dementia by our intervention. And this is actually true all the way up to something like 75, 80, where it starts to level off, because then you have mortality starting to compete with it. So it's really the message here is that it's the absolute risk that's really important. You have to choose a risk group either with a high age or with a high relative risk in order to get high gains in terms of the time without dementia. Okay, so that's the gain in time. Let's look at the costs then. So here is the net monetary benefits. We're taking all the difference in costs, and also we value the QALYs at 30,000 euros per QALY. And I've also shown this difference for the 3 European regions, so Nordics, Western Europe, and Southern Europe, because you have a different composition of the costs in these 3 regions. So of course, in the Nordics, we have a lot of non-medical costs. In Southern Europe, it's more informal care costs. But in total, it's fairly similar. So in our base case scenario, the overall net monetary benefits is about 2,500 euros over the lifetime of the patient. And of course, you get more benefit if you have higher effective duration and so on. You also see that most of the benefit is actually QALY gains. That's the biggest proportion. And after that, you have so in Southern Europe, informal care, and in the Nordics, you have non-medical. Medical cost is very, very low, right? And the reason is that patients with dementia actually have slightly higher cost of medical care, but then what also happens is that we prolong survival, and then you need to have medical care during that period of time. And that tends to balance off. So there's really very little effect on medical costs. We can also look at this in a different way. If we divide the net monetary benefit with the number of years that we are sort of treating with our intervention. And this kind of corresponds to how much could you charge for a program like this that's being efficacious? So how much per year could we charge for this and still be cost effective? So in our base case, this would be about 600 euros. So we could deliver a program like this for 600 euros a year, and then it would be cost effective from a societal perspective. Goodness is the finger program, I think, cost about 500 euros for 2 years, I think. So we're above, and that's consistent. We have shown before that the finger program was actually cost effective from a societal perspective. Okay, if we break this down by cost item, again, you will see that the majority of the benefit is in terms of quality gains and informal care and non-medical care, quite little medical care. All right, so just a final point here. I don't know how we're doing on time. Okay, final point in terms of the earn-in period. So how long does it take until you recuperated your investments? Assuming that if you have a program like this, you will have to pay for it up front, and then the monetary benefits will be accrued over time. So this graph shows you just over time, how long time does it take until you've reached the full monetary benefit of the program? So 1.0 is you've reached the peak of it. And it's also, again, it's quite similar between the different regions. For a 70-year-old patient, it takes about 15 years or so until you've recuperated the full value of the program. Of course, if you started with an older patient, you would have the mortality would be higher, and your earning period would probably be shorter. But the point here is that you'll probably have to wait until basically a big part of the remainder of the life of the patient in order to get the full benefits. And the reason is, of course, that we have a mortality benefit here. We're assuming that we prevent dementia, and that leads to improved survival. And to see the full effect of that, we have to wait until everybody's dead, basically. And that means that it takes quite a long time until we see the full benefits of the treatment. So there's also an issue here of kind of a time delay between when you have the cost of the intervention and when you get the benefits from it. Okay, so in conclusion, it's quite clear that dementia prevention can potentially lead to substantial health and economic benefits in at-risk populations. So what's really important is the absolute risk of dementia. And is mainly realized as a quality gain. So it's a health gain. So the argument here should be that we should invest in these type of programs because they are an efficient and cost-effective way of generating health. They will very likely not save healthcare costs. Maybe in some specific circumstances you can make arguments like that, but at least the modeling here, if you're focusing on the dementia prevention effects, that's not the main effect. So I don't think we should try to sell these programs in terms of cost savings. We'll probably also have to address this part with the time delay. It takes quite a long time for this to be realized, and you might have to look at different types of funding models and payment models for this to be viable. I think I'll stop there and take questions. Thank you.
Thank you very much. I guess that there's a number of questions that raised to your mind. I will again take the advantage. To what extent the whole concept is based on QALYs?
Yeah, it's based on both so direct medical expenditures and informal care and the health gains valued as QALYs, which is kind of the standard way of doing this.
Yeah, it's a standard way. The question is, to what extent do health payers accept use QALYs to inform their choices? Yeah. That applies not only to brain health services, but also pharma, any drug.
Yep, absolutely. Okay, so then we're moving into the question of, okay, who might actually be interested in paying for this, and what would they actually consider as evidence, right? So this what I showed you now tells you that from a societal perspective, this is a good idea to do it. Okay. And then the next question is, okay, who would actually care about this data, and what type of evidence would you need in order to convince different types of payers? Okay, and you're absolutely right. There's a limited number of countries that consider these type of calculations from a from a societal perspective when they make decisions around primarily pharmaceuticals, right? So it's Sweden, Nordics, and UK, and so forth, right? But most countries don't, right? So this is a model that's useful to think about the societal benefits, but when it comes to what actually payers care about, it's a different story. I think there's a reason why you've seen a mix of funding models for different programs that have been presented here. In my prediction would be that we will need a range of different funding models for this type of program, because it's something that has been, at least until today, very difficult for healthcare systems to find the way to fund. I think a number of reasons for that, and also a number of things we might do to change that, right? I think there's an issue with prevention in general, right? So in Sweden, there's even a law that says that we should prioritize programs aimed at sick people before programs aimed at healthy people. Okay, so we're actually not allowed to prioritize that. So that's one, and I think there's similar discussions. Now, of course, this is changing a little bit. We have more focus on prevention, but this needs to get into national guidelines as something that should be done. Second, it's also about then, if you're at the hospital, it's about what you can get reimbursed for, right? And then it comes down, in my view, very much to what evidence is actually available. So if we came today with evidence that we have today for dementia prevention, I think that the question will be, well, okay, this is fine. We can fund a program for dementia prevention if you show us that you can do it. Okay, so we need to have evidence that we actually prevent dementia. And what we have today is not enough. Honestly, I don't think so. I think we have to invest more in both in clinical studies and in health economic studies to show that these what I showed you, the theoretical benefits, that they actually happen in practice. And I think there's understanding that you can't do a single placebo-controlled, somehow randomized trial to generate this evidence. I think there's understanding of that, right? But I think we have to do something. And in addition to that, the evidence we can create for the fact, you might also have to look at innovative funding models that can take into account the uncertainty we will have left, right? Because it's quite hard to have definitive evidence for something like a prevention program that has effects decades into the future. So there are a number of suggestions that have been put forward. So one idea is health impact bonds and similar instruments, right? So the idea is that you have these effects in the future that the healthcare system may be willing to pay for if we show that this program eventually will reduce dementia incidence. We're happy to pay for it, but we will only pay for it once we see the benefits. So you have to find an investor who's actually able to front that money today, and then we will recuperate that once those benefits are realized. And there are actually mechanisms like that in place today for type 2 diabetes, for example, and different types of social interventions and things like that in different European countries. So I think that's actually a very interesting model to look at, and other similar type of mechanisms.
Okay, wow. One question from Mia and one over there.
Thank you, Linus, for highlighting this very important topic for many, and also these innovative payment models. I think we need to rethink, the whole thing, given that the benefit really may be there in the longer term. One more thing, I'm thinking, what evidence and in what way dementia, yes, but can we have also broader brain health? If I'm thinking adding, for example, the impact we could have with multi-domain interventions for cardiovascular stroke, multimorbidity, how could you have you been taking that into account in your models?
Yeah, of course, so it's a good point. So in this model here, I'm only considering the effect on dementia incidence, and it's very likely that if you have a multi-domain intervention program, it will affect cardiovascular parameters that will affect your risk of myocardial infarctions and strokes and all sorts of things, right? So we can include that in the model as well. The problem is that the more things you pile into your model, the more evidence you need to show that actually will happen as well. So not only do you have to show that you prevent dementia, now you have to show that you prevent myocardial infarctions and strokes as well, right? So there's a little bit of a balance there. Yes, we can put in these kind of risk factor effects that we see in the studies, like in the finger study, we see all these effects on the risk factors. We don't see the effects on the events yet, right? So I think there's a balance there. Yes, you will get even better results if you put that in, but how do we make that credible then? That's not just something we see in the studies, and because we lack the event trials on that, right? Great. So okay. Yeah.
One last quick questions and a quick answer.
Yeah, thank you very much. I have a naive question or a naive concept. Why do we always want to calculate the benefit or a reimbursement at an equal cost? We would save at an equal cost, not trying to save money. We would gain a lot of societal comfort and well-being because everybody, I think, in this room has experience of people, relative, that have the burden on, etc. And it's a huge social cost. And I don't know how we calculate that in terms of absenteeism, in terms of depression, and not in the patient himself, but in the surrounding.
No, it's a good point. There's of course a lot of kind of external effects of illness, and this is a disease that has a lot. It's in front of people's minds, right? But when you're a healthcare decision maker, they have a range of different conditions. Now you have the whole of precision medicine. You have all these rare disorders where you now have the ability to sometimes cure these patients, right? And you have huge mortality benefits in very few patients, and so you're kind of competing with all these other patient groups, which also have very compelling arguments for why that disease area should have funding. So in the end, it comes down to many things. It comes down to evidence as one thing, right? So I think that's what we can do something about here. It's the evidence, right? You can also make arguments that yes, this has further reaching societal consequences as a disease area. We should include that. Sometimes you can be successful, but usually not. This is it becomes quite hard-headed actually in these type of calculations. Yeah.
Thank you, Linus. Unfortunately, we must move on. Thanks a lot. I hope that we can work together in the future as a community. You are already working with Mia intensely. I hope that we can further work with you on these topics. There was a question also online, which was exactly the same from Jonathan Schott, which is exactly the same that Mia was asking. So I believe that Jonathan has got his answer. The next speaker is Maria Francesca Gellera from Deloitte. I don't think that Deloitte needs, it rings a bell in anyone, even in physicians like us. Maria Francesca, she will present the brain health model of the Geneva Memory Clinic. It's just one instance. It's very local specific. It's very Geneva specific. It may not be transferred elsewhere, but it may. You may have some inspiration. Maria Francesca, you will need. The microphone is there.
Thank you. Good evening, everyone. And I'm Maria Francesca. I think the introduction was enough. And on behalf of my whole team, I want to thank you for this invitation to participate and share our contribution. So starting our journey within the journey and focusing on the context, in view of the growing need of brain health services pilots, as we had the occasion to capture during the whole day, and to support the Geneva University Hospital team, we collaborated on this business case and business plan. Yeah, of course. Thank you. So the first step after the context is about the market overview, because we needed to perimeter what we mean by target. So the serviceable obtainable market that we see below, and we calculated it starting from the total addressable market. We are speaking about the Swiss context, so the total addressable market is about cognitive unimpaired over 40 and over 60 individuals living in Switzerland, of course, and available to check the risk of dementia. And we have here a potential range of 2.2 million and 1.1 million. With the same methodology, we calculated the served available market. And as plus, it's about individuals not living only in Switzerland, but in Geneva. And we have a range of 120,000 and 58,000. Then we were able to arrive to the serviceable obtainable market. And it's about the same individuals, but as a plus, tools available to attend a brain health services journey within the Geneva University Hospital. Of course, these are assumptions, but they were really relevant to have an overview and the potential target of the total available market. Going to the prevention model, an innovative journey has been defined by the Geneva University Hospital team, and it's really a matter of interest how everyone here is trying to provide an answer to these individuals' unmet needs and to prevent the possible course and worsening of cognitive decline. So we know, and I think we noticed also during the previous presentation, how there are some key elements on which the brain health services are founded on. Going from the accessibility of treatment, the social impact, the economic sustainability, the continuous research approach for the integration of the brain health services offer with the continuous research activities, and last but not least, the long-term societal benefits. Going in depth in the prevention model, I would like to give you an idea about the main assumptions we start from and the journey we started to design, and also the first key metrics that we will see deepen in the next session. So the journey will arise as an assumption within the current memory clinic, and this will, on one side, is the collaboration among the different departments, clinical departments, of course, and on the other side, it will contribute to minimize investments in machines, facilities, and facilitate the coverage also of the first provided services. We start in 2024, and we assume the launch of a pilot phase expected by, let's say, June 2024, on a first selected pool of patients. In 2025, we have the clinical deployment of the services, and we assume that the risk assessment and the follow-up phases and visits then will be carried out within the memory clinic or in external laboratories. But in 2026, the first patients will start to be redirected from general practitioners, and this phenomenon will even increase in 2027. And here we will also have a growing number of visits related to risk assessment and follow-up provided by the Brain Health Services unit. At the end, in the 2028-29, we expect that the journey will be fully provided by the Brain Health Services journey and unit. So as we see, it's an incremental path. And on the right side of this slide, you have some initial key figures about the number of patients. It's a cumulative number, and we start from an average estimation of 100 in 2024, and we arrive in the best scenario, of course, to up to 650 in the 2029. You see also the different key dimensions for the 5 phases of the whole patient journey. But which are the main key metrics, key numbers, key data that we needed to collect before going in depth in our model? We start with the cycle frequency per patient, how many times the patient could be engaged during the year, the duration of each cycle, the number of total cycle, the number of visit programs, and also the cost of patients. Of course, this work has been done for each phase of the whole patient journey, and we are speaking about risk profiling, risk communication, risk reduction, cognitive enhancement, and plus the follow-up, because it also needed to monitor the risk of the patient to face cognitive impairment during the years. All these key metrics and assumptions we already see in this journey with Dr. Federica Ribaldi were being used to elaborate the main assumptions and also to calculate the first average cost for the patient between this time horizon 2025 and 2029. We know that there are some synergies with the memory clinics because I already mentioned it. And of course, this has an impact in terms of costs. Then we assume also some discounted tariffs in the first years, going from the 30% in 2025 till the 10% in 2027. And then we expect full tariffs. For calculating the, let's say, maximum average of this cost per patient, we also are assuming an average patient who is starting the journey in 2025. He is performing the risk reduction for 2 years, the cognitive enhancement for 3 years, and the follow-up every year, of course, except the first one. So for the 4 different paths, and here are highlighted depending on the profile risk, from the low AD, low CVD, till the high AD, high CVD. So we have a range of 3.5 Swiss franc, 3,500 Swiss francs, till to 10,000, around 10,000 Swiss francs. Of course, it's an average and it's a first estimation, but it's important also to understand how the journey could be sustainable socially and economically from the patient. Okay, but which is our methodology that we can catch from this presentation, but not fully? Here we have some print screens, but I would like to highlight the main steps. First of all, the assumption definition phase. So we elaborated the main assumptions behind model data and calculation. Then, through a long cycle of interviews and sharing of materials, we were able to collect all the input data needed to perform this estimation. Then we proceed to calculate all the key figures in terms of potential patients flow, revenues, cost, and we perform these for each phase of the whole patient journey. At the end, we were finally able to elaborate the profit and loss, the overall profit and loss of the model, considering this launching moment for 2 analyzed scenarios. But which are these scenarios? Both of them share that the time horizon is of about 6.5 years, starting from 2024, as I told you, with a pilot, and then consider some different peculiarities. In the first case, the base case scenario assumes a limited number of target patients, a limited progressive growth. We are speaking about 10, maximum 20%, because we adopted a conservative approach. No investment in assets or facilities, but only in the medical devices needed to perform these first and to provide these first services. A limited investment in like the positioning, we call it marketing. Regarding the best case scenario, we had a greater increase in terms of number of obtainable patients, and we have also higher variable costs because we are assuming to internalize some activities in the brain health services unit, higher investment in positioning to increase the awareness of these new type of services, and also to comply with the broader needs in terms of business expansion, and also some investment in the capital expenditures. So the so-called, now we will see how. These are 2 views with the key figures of the base case and the best case scenario. I will go firstly to the revenues. The revenues here include incomes from the services provided, and also the rental of the medical instruments, which are expected for this first phase, so gamma tax, TMS. Then, as I told you, we assume some discounted tariffs for the launching phase, and also some inflection during the year. Regarding the main metrics of the costs, the personal costs have been calculated from the official hourly tariffs from the Republic of Geneva, and we have also an increasing year over year due to the seniority and the inflection again. Then the consumables and the overhead costs have been calculated as percentage of the revenues. Regarding the consumables, we are speaking about materials depending on the visits performed mainly. Regarding the overhead costs, we are speaking about infrastructure and personal costs mainly. And then other costs, I told you some positioning like brochures and a first event, and also a depreciation has been considered. Regarding the capital expenditure, we have the acquisition, so as investment, of the gamma tax and TMS machines to provide the first services. If we consider the revenues, then we have an average of 30,000 Swiss francs in 2024, up to 1,160,000 in 2029. The marginality, the so-called earning before interest and taxes, goes from an average of 11,000 in 2024 up to an average of more than 250,000 in 2029. Highlighting the main differences and the key metrics also of the best case scenarios. Regarding the revenues, the main difference is that we have, of course, a higher number of patients, but we are also internalizing the physical exercise, so the service linked to the risk reduction phase. Regarding the cost, we have a double effect, of course, from the 2027 from the internalization of the physical exercise activity. And we have also a double effect in the overhead cost because of the savings with the economies of scale on one side and the increase and due to the higher cost for the operation expansion on the other one. And then we have here more consistent costs for the marketing activities to positioning and also additional services, because we can imagine, especially in the capital expenditure, some investment in digital assets, in digital services, and in other facilities or machines or assets that we need to comply with these business expansion needs. Here we have revenues going from an average of 30,000 in 2024 and up to 3,200,000 in 2029. The marginality is still positive and the same as assumption of the base case scenario in 2024, around 11,000, up to more than 700,000 in 2029. Now, which are the main key takeaways, but which is the added value of this business planning process? I think, first of all, the economic feasibility. We supported the initiatives to ensure a positive marginality, but keeping in mind those key elements to respect. Then we supported to elaborate an innovative and socially sustainable model aiming at satisfying unmet needs, but of course, we are referring to the Geneva ecosystem. It's replicable, but it's very customized. We always adopted a patient-oriented approach, keeping in mind what the patient needs and what the patient is available to spend and to sustain for her path. We leverage on a complementary expertise. On one side, the Geneva University Hospital scientific and financial administrative teams working together, and on the other one, our multidisciplinary team, because as Deloitte, we have different expertise in the life science sector, and then both in the strategic and innovative one. Last but not least, which are the main next steps? So the first two streams regarding the brain health services definition and also the market and financial estimation that I show you before entails activities that have been currently completed, so they have been performed. Regarding the partnership and funding research in terms of research of possible partners and fundings, as well as the structure and clinical protocol set up in terms of recruitment of personnel, rent of rooms, and procurement of further facilities, the setup of further clinical protocols. These activities are still ongoing, are in progress. And at the end, the brain health services promotion and the pilot launch itself, selecting also a first pool of potential patients. Here, activities need to be started. As I told, first potential launch of the initiative is expected by June 2024. And some other next steps, of course, will be taken with a promotional campaign, a potential first event. I would now like to wrap my speech up by introducing you the whole multidisciplinary Deloitte team. I wish to thank all the colleagues. Some of them are remotely following us, Michela, Clara, Diletta, Ivan, and with the support of our partners, Gabriele, Guido, Christian. And then, of course, a big thank to you and to the Geneva University Hospital team, and a special thank to Professor Frisoni and Dr. Federica Ribaldi.
Thank you, Maria Francesca. And thanks, Gabriele, for working with us since the very beginning of this adventure. It's always challenging talking to people who speak a different language, even Italian. There's two different types of Italian. I have asked so many questions to Maria Francesca that I don't have more, but Frank.
Yes, thank you very much. So I think just to understand for me,
yes.
So you presented a business case in a way, and part of that business case was a cost of around about 11,000 francs per year. And Dino said that we can spend 600 euro per year to be cost effective, is it? Per patient.
Yeah.
How much is the cost per patient?
So the average it's from 3,500 per year for the lowest level of risk. And then for the highest level, it's around 11, so 10,000 Swiss francs. The thing is, it's an average patient. So this is the maximum because we are assuming that the patient is taking the whole cycle and he's not dropping out.
Yeah, thank you. So I think we just have to think about arguments for this program which are beyond cost effectiveness, I would say.
Definitely. Thank you.
Clearly, we are way beyond 600 per patient. In Switzerland, a consultation from a physician costs 200 and something per hour, 220 Swiss francs per hour, plus 23% sub. You say, Fisher.
That's very interesting presentation. Thank you. And I was wondering, and perhaps you told it and I missed it, but in my mind, it's quite a fundamental question whether the brain health service will be located in a separate organization, independent organization, or will be part of the hospital memory clinic organization. And in your model, I thought it was part of the hospital still, or?
Yes, I confirm. Yeah. It's the main assumption, and we are assuming that especially in the whole time horizon here considered, everything is delivered within the current hospital. But the thing is that since for the first years, patients will be redirected from the memory clinic to this brain health services unit, also some costs will be, lighter, let's say. But as facility, as infrastructure, the whole services will be provided along the whole time horizon in the current.
Yeah, so I understood. Yes. And I would have thought that an independent organization would also be attractive or feasible. Do you have any idea about that? Would it come out with a whole different business model, or is the difference not that big?
So from our experience in these kind of very innovative projects, it's important to adopt an incremental approach. So to proceed with the first launch and then to monitoring all the key figures, metrics, then to readapt and to proceed with the further launch. In this way, the model can be really sustainable. This is only, a first trial. Thank you.
Yes, what the assumption was that, or the starting point was that we already have personnel and some medical acts that can be already delivered. Take, for instance, history taking, neuropsychological assessment, MRI, we can give them already to our SCD patients, right? But the idea is to move slowly towards a separate things in terms in the longer term. We would like to have two separate cost centers. Okay, they may be in the same place, but they may mutualize some personnel, but two separate cost centers with two separate revenues, two separate budgets, so that you can, if you want to externalize one, you can do it. Richard.
That was terrific. So research is a critical, necessary part of this. But at some point, whether it's, I don't know, 7, 10, 12, 15 years from now, the research may be able to become maybe less of a high priority. In your modeling, did you ever think about how some costs would be reduced over time because the research infrastructure could be minimized, or haven't really gotten there yet?
Yeah, I have two perspectives to take here. Research costs have been partially included here, but also the other thing is that in the cost, we consider economies of scale. So with a higher number of patients and also with, a more consolidated model, we expect that in particular, the fixed costs are lower. Of course, the variable cost can be minimized, but depends on the number of patients, because it depends on number of visits and like all the other services provided. But the other costs, in particular the fixed one, yes, definitely.
I know there's more questions, but Maria Francesca and Gabriele, they're both available to answer your questions at the end of this meeting. We would like to shrink the times and move on. Thank you, Maria Francesca.
Thank you.
And move on to the roundtable. The roundtable will be chaired by Elena Moro and by Gilles Lally.
Thank you very much, Giovanni. Maybe I briefly introduce myself because sometimes I feel I'm a movement disorder specialist. I'm a neurologist, academic neurologist in Grenoble, France, 1.5 hours driving from Geneva. But we have the same passion for neurodegenerative disease. And I guess I'm here because I'm the incoming president of the European Academy, and the brain health is one of the major initiatives that we want to keep forward. So I think almost at the end of this exciting, very rich and inspiring conference, we need to have other stakeholders with us to tell us, well, at the end of this conference, what are really the challenges and the opportunities that we see as patients, as pharmas, as big society. So let's have this round table, actually half round table here. So I would like to invite, I think, our speakers, if they all want to come here, because this is a table. So let's eat together and share some food together. So I invite the patients advocates, the scientific society, professional networks, pharma industries, private research founders, and charities organization. I think somebody is online, right? Right, like it?
Yeah.
Yeah. So let's start then.
So maybe you should present yourself first.
So I start, Philippe Morillon. My name is Philippe Morillon. I'm representing two foundations, the Lennart Foundation from Lausanne, the Synapsis Foundation from Zurich, and the Alzheimer's Research Association. And we have kind of teamed together to give an opinion. Do you want me to talk now?
No.
Okay, so thank you very much first for,
Yeah, we just introduced.
Hey, I'm Legin Shawcross. I'm director of the World Dementia Council.
Yep. My name is Christian Steen-Frederiksen, and I'm a neurologist, and I'm here as a representative of the European Academy of Neurology, and I've also chaired the group of professional organizations that have met and discussed opportunities and challenges in terms of brain health services from the point of view of our different societies and organizations.
We have also.
Hi, I'm Martin Pang from Eli Lilly, representing industry, FPA.
Very good. And then I think we also have Hugo Masters online. I think, are you there?
Yes, I'm here.
Okay. So do you want to introduce yourself briefly?
Sure. My name is Hugo Masters. I'm the executive of Brain Health Scotland.
Excellent. And I think we have some private research funders, right? It should be with us. Okay, okay, so you are with us and not online. Okay, perfect. Okay, excellent. So I think we can start.
Don't forget about me.
Okay.
Hello.
So we don't see you. We don't
Yeah,
see
you
you.
cannot see me because I'm not allowed to start my video, actually. I don't know, the host doesn't allow. So I'm Lutz Friedrich, I'm a geriatric psychiatrist and I'm active in dementia research for a long time. And I'm here for those professional societies, you know. And I'm on the board of the European Alzheimer's Disease Consortium, and in collaboration with the European Frontotemporal Consortium, the European Lewy Body Society, yeah, that's my objective in here, and the Swiss Memory Clinics, of course.
That's fantastic. I hope we can see you when you
I
are
hope so
talking
too.
later. So maybe we start with Christian.
Yes, so yes, okay. So as I already alluded to, my role here is to represent the professional organizations that were invited to give their views on the brain health services. There were a number of different societies that were invited to give their thoughts on it, and you see them here on my slide. I will not go through them, but they represent a wide variety of different professional backgrounds. And we met twice online to discuss brain health services. And you will have seen this figure previously today many times from the paper on brain health services. And we decided to structure our discussion around this figure that's in the paper and to look at the vertical columns and to design some new horizontals that we thought were important to discuss when thinking about how to move on with brain health services. Now, in the interest of time, I will only present those challenges and opportunities that relate to the horizontals, because I think that's really where we as societies perhaps give most impact and have perhaps most to say. So in terms of organization and leadership, it was discussed that it's important to clearly communicate that these brain health services are different from memory clinics, and to also incorporate it seamlessly into the existing healthcare systems. There's a need for development of further technologies to enable brain health clinics for a number of different things, including computerized tests and also cognitive rehabilitation. And ideally, all this should be done in a partnership with industry to ensure the ability of reaching these goals. Moving on to education, there was a discussion that it's to educate about how brain health services differ from treating diseases, which is, of course, what most of us as doctors are doing, moving to prevention. It's also necessary for all who assess patients to also be able to assess patients or persons at risk. That goes both for neuroradiologists as well as neuropsychologists, and also to engage GPs in administration and interpretation of cognitive tests. There were also some opportunities, including the postgraduate educational program that has been launched by the European Academy of Neurology, which specifically focuses on brain health. Stakeholder engagement. So we operate in a space that has a multitude of different healthcare systems across both countries, but also regions within countries. and there's a real challenge in order to get brain health service incorporated into these very different healthcare systems. There are also opportunities. Many of the organizations that I represent have experience in communicating and discussing and moving stakeholders that will be important for implementing brain health services. There are already collaborations that we can build on, and we can use experiences from, such as the EAN collaboration. And it's also really an opportunity to work interdisciplinary within the brain health services. Ethics and resources. There were real concerns also associated with the prospect of brain health services. How do we avoid diverting resources from patients who are already at the dementia stage when we also have to care for persons at risk? How do we measure that the impact of brain health services really deliver on patient-oriented outcomes? How do we ensure that these services, which tend to be utilized by persons who are at a better advantage in life, so to speak? So how do we ensure that minorities and other underrepresented represented groups also use these brain health clinics? How do we, again, ensure that things such as imaging capacity is not used up by these by brain health services, and nothing is left for the memory clinics? And how do we handle individuals that are not interested in preventive measures? There's an ethical dilemma there. There were also opportunities, and that was that we could perhaps work to further destigmatize dementia, promote the idea that it is possible, it is manageable. Dementia disorders are manageable, they are treatable, and maybe also in the future preventable. Yes. So that was the horizontals, and I will, as I said, not go through the columns, the verticals. But in conclusion, I think it's fair to say that across organizations, we felt that there were many opportunities, but of course also challenges. We garnered a lot from our different backgrounds in terms of understanding how we see the different challenges and opportunities that are associated with the brain health services. And I think that we as organizations are positioned very well to help the implementation of brain health services. Thank you very much for your attention.
Thank you. Thank you very much, Christian. And is there any comment, any addition, any suggestion who you want to address? If I may add, I think this is the momentum for all the societies. We have a psychiatrist here. I think that the European Psychiatry Association, right, is also really pushing for putting together mental health and brain health. And really, I think we need to work together. This is really the time to do it in the European, but not only European, is not only our problem, it's a common global problem. So we have to join forces together. And I also think that health professional cannot do anything if we don't have the strength, the help, the inspiration of patients and patients' organization. We have the patient-reported outcome. They are becoming the most important outcome today. So we have, I think, the pleasure, right, Hugh, to have you with us. We hope to see you. We don't see you. This is quite right. So, but you can tell us something about your perspective from the Patients Association.
Okay. I can't start with the there's quite an echo. for me. I will just turn my speaker on. Okay, thanks. I think I just have 5 minutes. So I did have some slides, but I think probably everybody's seen enough slides today. So I'll just talk, if that's okay, for 5 minutes, and hopefully there might be some questions afterwards. I've come to this somewhat late, and I think it's only struck me during the day what the ask was. So I will endeavour to learn from what's been happening today. We've been collaborating with Sophia from Alzheimer's Geneva and Stephanie from Alzheimer's Switzerland to do this. We kind of struggled to get together, but so most of it are around my thoughts and the organisation of Brain Health Scotland and Alzheimer's Scotland. We'll continue to work on the template and populate that over the next period. I'm not going to cover the clinic. Craig Ritchie, oh, there we go, there's some slides there. I'm not going to cover the clinic because the Brain Health Service and clinic, because Craig Ritchie covered that in his presentation, but I think just important to restate that this is a Brain Health Service which is within Alzheimer's Scotland Resource Centre, so a patient or a person's resource centre organisation on the high street. People can just self-refer or be referred by their general practitioner and other referral routes. And it's a collaboration between the National Health Service, Alzheimer's Scotland and Brain Health Scotland, but also the Scottish Government. And somebody earlier said it was tricky to mesh research and clinical together. You should try meshing those three together, but we did manage to do it, and we have opened the clinic. So a couple of things that I think are important to talk about. Could we get the next slide, please? Seeing as we've got them up there. And the next slide. So yeah, next slide. Is it there? No, sorry, the one before that, it flipped forward one. If you could go back. Go back one more. That's great, lovely. So a couple of things really, thinking about those opportunities and challenges for our patient advocacy organisations to introduce brain health services, which was what we were asked to think about. But I also want to touch on people's experiences of using brain health services, and that's from the discussions that we've had beforehand and also since setting up the service, and probably that's an area that maybe hasn't been covered in great depth today, and would probably benefit from a separate workshop or event, because I think that's really important from a kind of patient advocacy point of view. So in terms of the language that we're hearing around this, that top left-hand point talks about people, patients, and patient advocates. And of course, patient advocate organisations or voluntary organisations that represent never talk about patients. So it's always about people. And in terms of the service that we're running in Aberdeen, most people come in as people and leave as people. Only a few people come in and actually go on to the clinic and become patients. So I think that's an important one that brings a certain element of conflict to patient advocacy organisations, and something that needs talked through. Similarly, not everybody, but some people have felt that there's a language of blame that can sometimes be around this. So terms like risk reduction, prevention, modifiable risk behaviours, for those people who already have a diagnosis of dementia or their families, there's just that sense of that, and that's quite a difficult thing, obviously, for people to deal with and think through. And then underneath it, we're still working through to be clear what it is, what we mean by brain health and brain health services. And I think today very much has been rightly, in terms of the audience, etc., been focused around dementia and dementia prevention. Whereas for us, I think what we're thinking about is it's much broader than that. And of course, it does start to actually go into other areas like other neurological conditions, and even into brain health, mental health and mental well-being. But that issue of brain health, dementia prevention, and we've heard other terms today that are beginning to to be difficult. And I think for the organizations, it's where are they placed in that sort of continuum there. So if you can flip forward a slide, and I'll just be quick. Yeah, on the next slide. Yeah, we have begun to populate this tiny writing. Terribly sorry about that, but and again, it's around those 4 areas that are from Giovanni's and the European Task Force paper. And I'll just pull out 1 or 2 wee highlights from each of them, really. And that one, the first one around organization and leadership. And the previous speaker, sorry, I've forgotten your name, but it's exactly the point you made. People are really concerned about what's going to be the impact on existing dementia services. Does this mean that that there's going to be less? Are they not going to be available? And also about who's going to go to these clinics, these services. Will it change the nature of how third sector or patient advocacy organizations work? Will it be a different group, and will people still be as welcome into these services as they were before? In terms of that one around sort of the stakeholder engagement, for organizations like Alzheimer's Scotland, Alzheimer's Europe, Alzheimer's Geneva, clearly there's a focus on dementia, whereas brain health is much wider than that. So there's a need to bring in a whole new group of people to get their voices heard, for those people who are just interested in improving their brain health, or maybe at these sort of early stages, or indeed just seeing around an early diagnosis. So that's a whole new group that needs spoken to. Education, I'm not going to go into. Leonie Visser covered that, I thought, beautifully this morning, but it's a real challenge to the organizations about, does it change, again, the nature of how you talk to people if you're talking about brain health, as well as for those people who have dementia. And finally, around ethics and resources, a big issue that has been raised with us, and one that's really coming through from the clinic, is the difficulties for the staff and for the service around talking for the implications of an early diagnosis, or even just attending a brain health service and going through the various sort of early assessments in terms of what does that mean for finance, for insurance, for driving. And we did a survey this year of 1,000 adults, and the majority had real concerns about attending a brain health service, or even somewhere where there was a brain health service, in terms of whether that would be logged and documented, and what that would mean for them going forward for all these really important issues. So that again may change the nature of it. There's a lot of challenges, but there are massive opportunities here for patient advocacy organizations, for the Alzheimer's organizations to engage with this. It's how we engage with it. We're immensely proud and excited about the service and the clinic that we're running in Aberdeen in Scotland, but it is one model and one that we will think how that transposes to other resource centres, other patient advocacy centres, and do they just have a lens on brain health and prevention, or do they go down this whole route of actually incorporating a brain health service? But I've found today fascinating, and thanks to everybody for speaking in English. I can't reciprocate. Well, I could in Spanish, but that wouldn't be much use. So thank you.
Quite a lot, quite intense, and I think we have a lot of things to elaborate. I don't know, Christian, he said that you share some common vision, so maybe you want to add a small comment about it.
No, I think that I guess we echo the same sentiment, coming from a bit slightly different approaches, because as I think a couple of speakers already touched upon, as physicians we are not really used to thinking in prevention. We're used to thinking in treating diseases. So I think a sort of a guttural reaction is to think, well, what about all the real patients, so to speak, if we are to treat all these patients that have risk factors? And I think in one way it's probably a healthy reaction, but of course it's also wise to think about whether or not
one is stuck in a slightly old, outdated paradigm of treating these end stages instead of treating the very earliest stages. And I do think that especially for patients with dementia have very different needs compared to cognitively unimpaired patients who are at risk, and we need to retain the language also to be able to formulate what these needs are to stakeholders as well. It shouldn't be lost in brain health services, and I think this is possible, but we just need to be mindful of that.
Thank you so much. Anybody else want to add any comment? Otherwise, we keep the round table. I'll let you, Gil, if you want.
The next
is we have the professional networks.
Yes.
Yes. If we, yes. All right. Now,
unfortunately, we don't see you.
Yeah, I'm not allowed to share to start my camera, unfortunately. And actually, I would love to present my slides from my screen. So if you let me share my screen, that would be most wonderful, as we did a minute ago. Could the IT do this? I don't want to see the slide from the auditor, but just let me share. Yeah. Okay. So I only have one slide. I hope you can hear me without an echo. So, I mean, I speak here for this professional networks group, and much of what is on this slide has been said from different angles already, of course, yeah. But in our discussions, we came up with the point that dementia, there is a difficulty to see dementia prevention from the angle of a medical therapeutic task, as is usually seen in memory clinics and medical organization, or as more as a political action in the sense of public health and health promotion. So this relates actually to many distinctions, and the last one Christian has said, to keep this clearly apart is also an important point. And because at first sight, of course, existing memory clinics appear ideal to implement such activities like brain health services, because there already is a lot of expertise and complex assessment and communication skills. This has been all shown by the pilot presentations before in more detail. And of course, we also see, because of there is a very high motivation to extend dementia prevention and treatment programs in conjunction with research activities. And this is also a particular pro in a way. But of course, I think it is important to keep these services as more distinct organizations, because it may be worthwhile not to consider this much as a medical task, more as an educational task. So to avoid this topic of making everything as a disease, as a medical treatment, and it's part of general health promotion activities. And of course, this relates to reimbursement problems for these general health promotion activities. And expert centers like these memory clinics networks are densely available in Switzerland, but not so much in other European countries. There are two specific points that we would like to mention, and this is about the risk stratification along biomarkers, genetic markers, and or for specific diseases, which was also a particular point that this research-oriented memory clinics may have a lot of data and infrastructure available to make this more distinct. But the actual evidence for differential risk profiling and so is very much lacking, and there's a lot more research needed. So, and the last point that I would like to mention is coming back to the more public health or general health promotion aspect. So the question is, why not to see lifestyle modification as part of a self-administered health plan? Because generally now we have only evidence that these modifiable risk factors are not very specific potentially, and there is a lot of activity on e-health or mobile health devices which are already in place and developing and in use, unstructured more or less. And all this is going outside the medical area, more in a framework of social determinants of health. This would avoid these particular general reimbursement issues and the discussion that Linus has alluded on how much value to assign to it and so. So this is more on the level of self-promoting things. And this may, of course, be integrated with more public health activities and in collaboration with more general medical areas like general practitioners or even the payers, the insurance companies. So, so although it's quite attractive for the memory clinics by themselves to work in this field, but I think there always has to do with a lot of research and development, and for implementation and the general spread out over the real world, there might be other areas as much as well as within that memory system. Thank you.
Maybe I start with a question. From your professional networks perspectives, do you see any specificity by disease? I mean, do you think that? Yeah.
I mean, from this general medical or expert-centered perspective, in particular, frontotemporal dementia may have, even in the beginning, quite a different profile and different phenotype of deficits. So to work on these deficits or promoting sort of health activities or maintaining the self-autonomy, and so it might be worthwhile to consider of rather different interventions than with the general memory decline that is connected with Alzheimer's disease.
Thank you very much. Any comment from the audience or from the table? Yeah, Giovanni.
Yeah, I would like to contribute with a potential scenario that might take place in the future regarding this debate between about should the dementia expert be in charge of doing dementia prevention? Should it be something that the GP should take care of? I believe that what we're discussing here now, when we talk about brain health services for dementia, is to develop pilot experiences that might over time trickle down to GP, to the population prevention. Once we put in place effective programs, then some of them may be delegated to the GP. Think in terms of the vascular prevention. Vascular prevention today is largely done by GPs, but we still have hypertension clinics. We still have clinics for lipid metabolism, the problems of lipid metabolism. We have diabetics clinics. Who are the customers? They're the most difficult patients, the ones at higher risk. But the vast majority of patients at middle higher or middle risk or low to middle risk, they're delegated down to the GP. Now, before delegating, well, we need to develop something that works. And this is what we're doing here. When we have something, working programs, then we can delegate down to the GP.
There is another, maybe, and then Dorota.
Yeah, no, I just fully agree. I think from the financial point of view, if you want government to pay, you should not create another silo. So you can create a pilot, and then you have to have this continuum. It has been alluded to already this morning. I think this is very important. We have a medical community here.
Dorota, maybe.
Yeah, this is a very good comment if it's public health issue or healthcare issue. But one thing that Christian didn't maybe highlight so much, even we take its medical issue, healthcare system issue, this prevention job, it would be important to save our staff, because staff usually like to work more nowadays in outpatients clinic. So usually if you see early dementia, you don't see moderate dementia and severe dementia. So the working possibility to find out new possibility that staff can both work with prevention, which is maybe a little bit soft type of work, if you agree. I don't know, maybe you don't agree. But then if it's half time would be in this hospital setting and long-term facilities and so on, this would be really needed, because otherwise we will have a shortage of staff if we move so much from medical staff to the kind of public health intervention. I think it's really important to take care of our staff as well, give them possibility to work and also healthy aging as well.
Yeah, thank you very much.
With the burnout of the young generation.
Yes, exactly. Yeah. So now we're going to move to the charities and international organizations.
Oh, yeah, I can speak from here, actually. That's easier. So thank you very much. I will just, by way of introduction, say my background is politics until we lost the election, and the thinking about cost-benefit analysis. And I can say this because I'm no longer in frontline politics, but I worked on a 5-year time cycle, which was a general election, and it's beautiful to have benefits in 20 years' time, but that is someone else's benefit, and it's not going to be mine. And I think that's a problem for lots of these conversations. So I don't have my ticker, and I'm going to be quite brief because it is the end of the day. So someone can flick the slide on. These are all the various bits of organization. I'm not sure who's flicking the slide, but regardless of that, I shall continue, which is, I will make 3 points generally linked to the much wider public policy landscape. And I'm going to skip over some in the benefit of time, which is firstly the critical importance of embedding anything in whole life public health strategies, because in terms of how, like, for what is attractive for policymakers, that is an attractive proposition. And you are justified in paying some costs, and setting up bespoke services that deliver, over 20 years' time is a much less attractive proposition. I put various bits and bobs down there, but I think one of the quid pro quos is that often when we talk about prevention and brain health, we end up sounding like we just want the public to do something. And actually, too often, we leave others, and by we, I mean the dementia field, leave others to talk about the structural factors that have a huge influence on someone's health. So, air pollution, which came up ages ago, is clearly a matter for government. But, you look at something like smoking, and there's actually a lot of public policy that makes a difference in a way that interacting with an individual is far less significant. And actually, you need a lot of political space for that. I did the smoking ban on pubs and restaurants in the UK, and you would have thought we were abolishing all pubs and restaurants for the amount of political opposition we got. 20 years on, it's inconceivable smoking in a restaurant in the UK. At the time, you would have thought we were killing it. So there is a kind of, if we talk about prevention, we also need to talk about the role of government. And I think that, and the second is around delivering this, which is that it has to be embedded in national dementia strategies, because they are a vehicle that people understand. And 1/3 of people are going to go on and die with dementia. And like governments across Europe, governments in the United States, get it as a way of delivering it. And if you end up talking about something that sits outside a recognized policy framework that exists, whether it's long-term prevention strategies or national dementia strategies, and come along with a price tag, it's much less attractive to deliver. And the final point that I would make, which is around this public health messaging, which is I think there is a gap between what the public thinks is possible and what professionals think is possible. And it's a bit around the kind of various cost benefit analysis. And if you think, Giovanni, of your original slide, that poor bugger who, needed to give up alcohol, needs to give up smoking, needs to lose about 20 stone and take a constant exercise program. I mean, as a cost benefit analysis, I'm not surprised people say, well, would a Sudoku kind of work? Because I'll just try that. It's a lot easier. And actually, the prevention to be sold to the public as a cost, that there are genuine benefits for them that gets them taking activity, I don't think is kind of sold into the public. And to do that, you need governments to shift the way they talk about the disease of dementia and about what you do. Because if you look at most European public awareness campaigns, they are entirely focused around attitudinal, and they're not around either public health or getting treatments. And the final point I put on there, reference to the kind of stuff around patient advocacy earlier, is that when we talk about public and patient involvement, we basically mean people who've got dementia and have got a diagnosis of dementia, because de facto, they're the only ones who turn up to the conversation. But all of this conversation today has been about people who don't have diagnosis and who don't have dementia. And they are not involved in any kind of public advocacy whatsoever. And I think that's one of the biggest political challenges, is that you kind of want to deliver things for people who don't really see there's a problem and are not lobbying politicians. So there is, to go back to the patient organization point of view, as the disease of dementia changes, there is an important role for patient advocacy organizations to think about how they understand and engage people who are at risk of disease, but would never think of turning up to Congress or would never think of sending a letter to their politician, because those are the people who are ultimately going to become advocates for prevention funding. So it was vaguely what I had on the side. Oh, and I'm going to make one last point, because it is the end of the day and I can't resist it, because I've seen your Churchill-Roosevelt slide before. And this is very much tongue-in-cheek, because it is the end of the day. But, it's absolutely true that Roosevelt died shortly after the Yalta conference. But, I'm British, obviously. Churchill drank champagne for lunch. He had a bottle of wine with every dinner. Like, he had a brandy every day after dinner, and he finished the day with cognac. Roosevelt died at 65. Churchill lasted to 90. Make of that what you will.
That's great. So I remind the expert patient. I think you really want to stress the role of the patient in helping this campaign, and also maybe the genes that Churchill had. You need to study the DNA of Churchill. And now the pharma representative.
So I'm representing FPIA, not only Lilly, the company I work, and we agree on some points and link it to all the discussions today. So in the elderly asymptomatic patients, amyloid is a clear risk factor of cognitive decline, as we have seen in the study A4. So the more amyloid you have in your brain, the greater the cognitive decline. And amyloid was detrimental of brain function. Removing amyloid from the brain at the early stages has shown greater slowing of cognitive and functional decline, as we have seen in two phase studies already, in two phase 3 studies, the Clarity AD and the Trailblazer ALS 2. So the earlier you treat with an amyloid targeting therapy, the greater is the clinical benefit. And yes, we have ARIA, the most frequent adverse event with these therapies, the ATTs. And we know now the main risk factors, and we know that is less frequent in the early stages of AD. So therefore, with these 3 pieces of evidence, we can conclude that the ATTs, the amyloid targeting therapies, have their greater benefit risk balance in the earliest clinical stages of AD. And I mean, I was a bit shocked yesterday when I could see that some of the experts consider that these drugs are still very, very, it's not clear, the safety profile. And I think we have now very robust evidence. And if we don't benefit from the innovation that is coming now, how are we going to fund and foster for future innovation? That's a big concern, no? So as it was presented by Cummins, the ATTs in preclinical ED are currently under 2 phase 3 trials, and we expect the readouts of AHEAD 3-45 by the end of 2026. And it's possible that there is an accelerated approval if there is a positive interim analysis. And donanemab from Lilly has the Trailblazer 3 that was as well presented, ongoing, and the readout will be at the end of 2027. So I would say that it's very, very important to consider the implementation of the blood-based biomarkers as soon as possible, as soon as they are available. And when I say implementation, I mean when there is regulatory approval to ensure access, reimbursement, and validate it, and include it in the guidelines, because this will allow timely and accurate diagnosis to enable the clinical research at scale in this very, very early stage in preclinical AD to tackle it. So I would ask the experts to acknowledge that there is an increasing evidence to prepare for this potential change in the paradigm, that the amyloid targeting therapies' greatest benefit risk, I believe, has been demonstrated in the early stages of the disease, in early symptomatic clinical stages. So there are promising upcoming trials. We'll see the results. The evidence for the target patients is clear, I think, at the moment. We'll see what EMA thinks, or the regulators already have expressed. And for the very, very early stages of the disease, is pointing in the same direction, hopefully, but we need the evidence. So once the evidence is there, I would say we need to consider as well that non-pharmacological approaches are complementary, and they will need to be assessed with the same rigor, with the same methodological standards as the drugs, to be able to inform public policies. And innovation should be used as long as it's available to foster future innovation. And current innovation is coming at a state of maturity, I believe, after so many failures, to create incentives to be able to move forward with future innovation. Thank you.
Thank you.
Thank you very much. Any comments, very quick? Yeah.
Well, I would like to object to the fact that you said that we should have the same expectations with regards to evidence and the same rigor for non-pharmacological and pharmacological treatment. I don't think that's true, and I think we should be mindful that the randomized controlled trial is not the ultimate test for all therapies. Yeah, that was just my comment to your presentation.
Thank you, well taken.
Maybe I have one comment. I think for the industry, it's important to understand, from my point of view, that the antibodies are probably not the way we can prevent Alzheimer's disease on a large scale. I don't think that healthcare systems, because of costs and also because of still risk, will be able to uptake monoclonal antibodies for prevention. So it's a task for the industry to come up with safer and potentially cheaper and easier to take drugs for prevention.
May I have a follow-up, Martin? I believe that what we're seeing here is that, I do not want to reiterate what everyone else has said, but we agree that in those with cognitive impairment, monoclonal antibodies are effective, period. In those without cognitive impairment, once we show that they're effective, we will need to make a fine grain of those at risk because they have amyloid. There will be those who are at very, very high risk because their conversion, the development of cognitive impairment will take place in a few months. And there will be those who most likely are 20 years before cognitive impairment. Mm-hmm. So that's a different fine grain of risk. For the first case scenario, those who are very close to developing cognitive impairment, we probably may wish to go to run the risk of ARIA that we know and give them monoclonal antibodies. For those who are 20 years or 30 years before the development of cognitive impairment, I don't think that we can do that. So it's like if you take another model, the prevention of stroke in those with the prevention of stroke. If they have atrial fibrillation, well, you go for anticoagulants. But if they've just some plaque, carotid plaques, well, you go for aspirin, for low dose aspirin. I believe that might be how the field may evolve in the future.
No, it looks, I mean, not possible, not feasible, and not reasonable to treat chronically asymptomatic patients. But maybe the regimens for this population are much shorter. And I mean, there are models of reaccumulation that point out to that as well. So maybe a few doses we have to see. But the case has to be clear, I agree, and the evidence has to be in place. It will not be in a couple of years. It will take longer.
May I have some comment? Following Frank's comment, we do have demonstration by phase 3 trial that the donanemab, lecanemab make the job. But you should remember that this trial are based on very strict inclusion and exclusion criteria, right? Mm. So the reality going to be very different because we won't be on this very strict selection. So could you please comment on that? Because today we'll need to see if we can translate the phase 3 trial to the reality.
So we have limitations methodologically in the trials to 18 months because it has been very, very costly to develop these drugs. And that was the agreement with the expert community and the regulators. And that's limited, I agree. So we need long-term follow-up and the same, even stronger for the preventive indication, I would say. So that has to be done probably in high quality real world data. In the case of MCI, and even more strongly, I would say in preventive, we will have to have in place the systems, which they are not at the moment for neither of the populations. I fully agree, but it needs the translation. I cannot more than agree. Yeah.
Thank you very much. So we're going to close the debate with
Thank you.
Maria.
So I'll try to be a little bit entertaining. Who pays? I have a preliminary comment here. I just thought about the price of elderly homes here in Switzerland. So that's about 6,000 francs per month, more in euro, of course. Time, say, 1,000 people in the Geneva area, probably more. That's 6 million per month. Time 12, that's 72 millions per month, per year. We could think of transfer of charge because people usually pay it by their own, through their own pocket or by family or maybe social insurances. So just a few words. It's a great meeting. I learned a lot. And of course, I think everybody agrees that these centers should be developed. And I have just 3 comments. One on the governance and responsibility. The second is on communication. And I'll take the example of HIV because my background is infectious disease. And the third is what can philanthropy do?
So there's the first is governance and responsibility. If we all agree that dementia, and I think it's well demonstrated, is a public health problem which will grow, then because it is a public health problem, it should be covered via public funds and solidarity. We're all touched. We will all be indirectly or directly touched by this, and there is no way that we make profit out of that. There should be really, and this is not a political point of view. It's just a humanistic point of view, and philanthropy. The three, at least, philanthropic foundation would mention that this is one message. It's another thing as a secondary. If you create these centers that are useful, and then you need research funds or new drugs, etc., then there are, of course, partnership with pharma or with the diagnostic industry. That should just be framed in the normal, at least in university and hospital, in the normal ethical and legal framework. That is obvious. But the basics should be really the conscience of politics. And I go back to you. So about communication and the example of HIV, that was mentioned several times, and I'm just quoting here Leonie Visser. We need to convince, of course, the politician. Brain health services will not be therapeutic centers, but preventing centers. And in Switzerland, and I heard today also in many other countries in Europe, the healthcare system is disease-oriented. It is not prevention-oriented. So it does virtually, or it does just not pay for prevention. Therefore, brain health services will have to convince, and in order to convince, they have to prove their efficacy. This will take a lot of time. And here's the HIV example. 40 years ago, as a young fellow, I saw the first cases of AIDS, and nobody dared or almost dared to pronounce HIV or AIDS because it was a death sentence, not only for the patient, but for his or her relatives. That was terrible. Yet, research went on, and cohort research with thousands of people that would have no future, but just be followed. And during this 20, 30 years of just follow-up, we learned something very important, which you already know with the disease you're interested in, is that the AIDS, the immunodeficiency related to AIDS comes 10 to 15 years after the original infection. In between, there is no symptoms. So, and we also learned that if you had any therapy, like the heart therapy that we have, the highly active therapy now, it has to be given during the time where there are no symptoms. It's the only way, because if you give it later, there will be problem anyway. And we know now that giving these drugs, which are, by the way, quite expensive, people get a life expectancy that is quasi-normal. I think this is a very important message because it is a kind of similar scenario, and people may get convinced that we have to do something early and not wait until the symptom when it is too late. So this is just an example. Then what can philanthropy do? So public health system or government will not be fast in covering these new centers. You mentioned it was mentioned everywhere. It's not only a question of political will, but it is a question of just, it takes time. Administration takes time, and you have to play with budget. So there are at least two ways philanthropy can help. The first is a seed money state philanthropy partnership. And I take the example of Lausanne. 12 years ago or 10 or 11 years ago, the state decided to have a plan for elderly people, but it had no money. So philanthropy helps, and they teamed together. The Lennart Foundation, I was not there at that time, provided
for over a 5 years period of time, the salary for a professorship plus some research. And the state provided offices and some salaries for technician and for the clinics. That was very successful, so successful, not thanks to us, but thanks to the people that were working, that they got more grant, and they got more investment from the state. So you may not
comment.
Anyway, so the second way is that in order to convince people, it will take time, like the HIV story. It will take 10, 15 years. It was also alluded to prove that. So you'll have in these centers to have clinics, but also research, and that was just repeating what was said, but long-term research, cohort research, and demonstrating and learning also by walking little by little that this is useful, and having new drugs entering and blah, blah, blah. So who will pay for that? The state will not pay for that. Maybe competitive grants may pay for that, but not at the very early stage of exploration, usually not. So to pay for this Death Valley before you have an early proof of concept and you can write a European grant, I think philanthropy can pay that, and they are interested in doing this facilitation. So these are the ways where we can work with you, and I think that's my message from the philanthropy.
Thank you very much, Felipe. Yes, just want to comment something you said about the fact that dementia is a public health issue. I'm sure we are all convinced of that. The politics are convinced of that. Maybe not all the medical doctors are convinced on that. But how about the community? Is the community convinced that dementia is a public health issue? There is a kind of fatalism in the community that when you become old, you become demented. And if the community is not aware about the fact that we can prevent that, and even that it is a disease behind this dementia, I think this plan and what we saw this afternoon with the brain health clinics, we saw that the education level was very high. So that means that the risk is that we're going to target just a minority of the population, the one who has the chance to have a good education.
Not sure of that. I mean, it will take some time, but first there are many people that will be confronted and are already confronted with that problem. Not the youngest, not the 20 years old guy, but the 40, 35, 30, etc. They are confronted with their parents, with their family. Yes. No, I don't know.
Das Dauergummibärchen gefressen die ganze Zeit.
So it's our task and the task also of the politics to explain this, because when you see your mom, your grandma, your aunts, etc., entering in these phases, and there are sometimes very young people, I mean, relatively young people in the inheritable disease, you become convinced. With HIV, it was the same problem. Nobody talked about. Then we started to talk, and nobody cared, even the exposed people. And now it is going much better. It's going worse again because of heart. But anyway, I mean, the situation is more or less managed, at least in the European countries.
I just want to say one sentence on HIV in general. So, you know, as a gay man, I get tested every 3 months for HIV because for cost-benefit analysis of not realizing that I have HIV and waiting to the point that I've got AIDS is huge. You know, you really, really, really want to find out if you're HIV positive, despite the fact that I still take PrEP daily to like save off. It still makes sense to get yourself tested for HIV. The challenge for communicating prevention in the dementia space is the cost-benefit analysis for an individual who is aging is a lot lower. You know, it's a lot less favorable. And until we can kind of persuade the public, but they really, really need to do something, like in a way that every gay man would now be like, I need to get tested. That's the challenge.
Don't know if you maybe you want to add, and then we have to wrap up, right?
Very fast. I think there are many parallelisms as well with MS, multiple sclerosis. When the first disease-modifying drug came up, natalizumab, it had PML, a very severe adverse event, and it scared many doctors. And then there was rescoring, but it took many, many years to convince each of these physicians who would have just one case. They would go then to interferons, and they would be very conservative in treating patients and not saving years of accumulating disability. So we may be in a similar situation or exactly the same in AD, but we have to be cautious not to be extremely conservative, I would say, and save brain as much as possible, and learn more about the drugs, as you pointed out, in real life, because they come very short of evidence, of course, because of the difficulties of developing them.
I don't want to prolong, but when we talk about that, sometimes the brain is really your tool of autonomy, and I think Stephen Hawking is the best example. Totally crippled, but you can keep an autonomy now that we have robots and everything.
Yes, thank you very much.
Yes,
Giovanni?
thanks everyone. Thanks, Christian. Thanks, Martin. Thanks, Gino, Elena, Lenny, Philippe. Now, we just have 35 slides to conclude. Yeah, 30. No, I believe that it's very late. I don't have the...
It's here.
Okay. I don't really have much more to say. I have a few slides to show you that we did some homeworks. We tried to summarize, to find common themes on these pilot experiences that seems disparate, but there are common themes. We've tried to summarize that. Well, Federica has done that. In terms of the environment, the risk assessment, risk communication. This will be the starting point of a paper that will come out of this meeting, that will address the pilot experiences, the business case, and the challenges and opportunities from the other stakeholders. So this is the next step, consolidating what we've discussed in a paper. Of course, it will be very nice to meet in sometimes from now to have a follow-up of what we've been developing, maybe add more people who are interested in the field in 1 year, 2 years. I don't want to create expectations. We've already discussed about not over-promising, but this is the plan. Having said this, from my side, I would like to thank the sponsor of this initiative, without whom, you've seen them a number of times. I would like to thank those of my team who contribute to this, and those from Lausanne who helped to organize this meeting. And I wish to thank you all for being here. And I let Gilles say a few words.
Yes, I think you should thank Giovanni Frisoni for this initiative. Thank you very much, Giovanni. And thank you very much for coming and for your interaction with the speaker. Thank you very much.
Thanks, everybody, and see you in some times from now.
Thanks, Giovanni, and everybody. Bye.
Thanks to everyone who was online. Thanks, Lutz.
See you.